I request all the students to take the seats. I request our Secretary of ECCON, Dr. Parle sir, to say a few words on this occasion.
Hello, good afternoon everybody. Welcome to Solapur and welcome to ISACON. Perhaps many of you might be for the first time visiting Solapur. That's why I'm saying welcome to Solapur. Congratulations to all because your paper or poster has been accepted for presentation. As you know that your paper or poster that will be assessed, given marks, and top 2 of you would be entitled to get a prize, the cash prize of 10,000 for the topper and 7,000 for the runner-up. And also, most important is you will get a complimentary lifelong membership of ISE, Indian Society of Electrocardiology. So that's enough incentive for you to compete, but relax. This is not your final MD examination, and you should use this as a learning experience to answer the questions. All the examiners are very friendly, and you should use this as a learning experience because you will be giving your final MD examination soon. You would be assessed, your presentation will be assessed under various headings. First, it will be novelty, originality will be allotted certain marks. Then the second will be the clinical applicability of your paper. Third will be your presentation, the slide design or the type of presentation that you have, how attractive it is. Then, and the final will be on the questions, the answers which you give to the questions posed by the examiners. So you will be assessed along these various headings, and then the final score will be calculated. Anyway, relax, go ahead, all the best.
Thank you, sir. Today we have the paper presentation and poster presentation at M floor. In Hall Gel, we will be conducting the paper presentation by myself, and Dr. Siddhant Gandhi will conduct the poster presentation in Akash Hall. For paper presentation, total 9 minutes are allotted, 6 minutes for presentation and 3 minutes for question and answers. And for poster, 4 minutes for presentation and 2 minutes for question answers. Now we'll have a group photo here, and after that, those who are having paper presentation, poster will go upstairs at M floor. So I request all to come on the dais.
invite the chairpersons, Dr. Satish Godse, who is a very senior physician in Solapur, and Dr. Rahul Karimungi, who is a cardiologist at Ashwini Rural Medical College, on the dais to chair the session. I also invite Dr. Kedar Karpe sir, who is the speaker for today's session. Sir is a senior interventional cardiologist at Yashodhara Multi-Speciality Hospital and SP Institute Solapur. And today's topic of talk would be basics of ECG and conduction systems of heart.
Shall I start?
Yes, sir.
Okay. Good evening, all of you, respected chairperson, my teachers, seniors, and colleagues. Today it is, I am very happy and pleasure to present as a first presenter. My topic is basics of ECG and conduction system of the heart. So coming to the introduction, ECG or EKG is derived basically from a Greek term cardia, which means heart. Basically, EKG is used basically in United Kingdom or for European countries because they feel ECG in pronunciation looks like EEG, which is electroencephalogram. So many of the foreign countries they use EKG, but in our scenario we commonly use ECG. So ECG is an important screening tool that offers a practitioner wealth information that can be used along with the history and clinical findings. Despite widespread use of ECG, many people struggle to master the basic of ECG interpretation and errors in the interpretation, which can lead to misdiagnosis and delay in appropriate treatment. ECG was basically invented by a Dutch medical doctor and physiologist, Willem Itoen, in 1895. And the same research, he got Nobel Prize in 1924. So before going to other thing, I want to talk about the ECG paper, which is very important. So this is ECG paper, everyone knows that. We'll just highlight this small square, which is very important. This is y-axis, where you can see that it is amplitude, and this is the x-axis, which is for duration. This is for voltage and this is for duration. This small square is equivalent to 0.1 millivolt, which is also equivalent to 1 mm. Here we have taken 0.5 millivolt and 5 mm. And this is a duration on the x-axis. Each small square is equivalent to 0.4 second, that is 40 millisecond. And this 5 small box, that is one big box here, is equivalent to 0.20 second, that is 200 millisecond. So 1, 2, 3, 4, 5 is equivalent to 1 second. This is very important on amplitude. See, many of the ECG, if the amplitude is kept 0.5, then you will get a half standard ECG. And normal amplitude that is standardized is 1 millivolt, that is a 10 mm. And sometime by mistake, the ECG machine, they will keep at double standard. Then we will misdiagnose the ECG with as a left ventricle hypertrophy. Coming to the ECG leads, the ECG leads has been divided into like the total 12 leads, which has been divided into limb leads, which are also called as the Ethiopian leads. Which lead 1, it will start from right arm to the left arm. Right arm is having a negative electrode and left arm is having positive electrode. The electric current or vector starts from the negative to positive electrode. Lead 2 is from a right arm to the left leg, and lead 3 is a left leg to left arm. Augmented leads, also called as a Goldberg's lead, basically this has a single, above leads are bipolar leads, these are unipolar leads. Unipolar leads, and they are AVR indicates right arm, AVL indicates left arm, and AVF indicates left arm. Their voltage has been augmented, so it is called augmented leads. Then chest leads, which are called as a precordial leads, which are V1 to V6, sometimes V7, V8 also is used in posterior MI, and right sided we use in RVMI. So electrode are conductive pad that is attached to the skin and enables recording of the electrical currents. Electric currents moves from negative to positive electrodes. Electric currents from the hearts are conducted all the way to the skin because the tissue and fluids surrounding the heart act as a electrical conductor. And many people, they have the question where we should keep this electrode in amputated people. In amputated, limb leads can be placed at the elbow, shoulder, knee and hip depending on the amputation stump. So coming to the ECG electrode placement, first we'll talk about precordial list. V1, it is placed at a fourth intercostal space on the right side, just border to the sternum. A same place on the left side is V2. V3 is in between V3 is at a midway between location between V2 and V4. V4, it is here down. It is at a mid clavicular line in the fifth intercostal space. And V5 is at anterior exit line at the same horizontal line as V4, and at mid exit posterior, it is at mid exit line. We have a V6. And this limb lead which I discussed already, they are shown that only we can use from left shoulder to left elbow. So coming to the cardiac cell, this is the intracellular, that is inside cell, and extracellular fluid that is outside the cell. Everyone knows that intracellular has a high potassium concentration, extracellular has a high sodium concentration. Our action potential mainly depends, that is exchange of ions depends on the two things. One is, this one is a ion channels where only the transfer of the ion occurs according to the gradient in only one way. These are the pump where two ions, they move according to that one at one time. Sodium potassium pump, here the sodium comes inside and potassium goes out. In potassium channel, it is only one way, potassium goes out. So at the rest, all the myocyte cell membrane is slightly negative, that is around minus 90 millivolt. The electric impulse, when it arrives at the cell membrane, it causes sudden influx of the sodium and alters the electrical polarity of the cell membrane from negative to slightly positive. This change is called, in electric potential, is called depolarization. Once the cell has been depolarized, calcium channel opens and the calcium enters the cell and stabilizes the electrical charge across the cell membrane and closes the sodium channel. This is where we find the plateau phase in the action potential graph. I will talk next. And calcium flows slowly into the cell and creates the electrical plateau phase. After contraction is completed, calcium channel closes and potassium channel opens, and potassium flows briefly from the cell, which leads to repolarization. The whole process of depolarization and depolarization is described as action potential. Action potential gives rise to a wave of electric current that spreads rapidly across the tissue and gives rise to ECG wave. So this is action potential, what I was speaking. You can see this is a resting membrane potential, that is around minus 90. Once the sodium goes inside the cell, the voltage increases, and that is called depolarization. Here the calcium channel, which are mainly intracellular, that is from the store of the cells, they will open, and this causes a plateau. Here only the contraction of the myocyte starts, and at this phase the calcium inflow is stopped, and then the potassium goes out of the cell where the repolarization occurs. This I just shown that how it starts. See, inside there are all potassium channels, potassium it is there all negative, outside is positive. Once the depolarization starts, it starts from one side of the cell, then this is a partially depolarized, then fully depolarized, and then again the repolarization starts. Then coming to the ECG wave, this is P waves, then from end of the P wave to the start of the QRS complex, it is a PR segment. PR interval is starting of P wave to the start of QRS. Then QRS complex is starting from QRS complex to the end of S waves. Then ST segment from the end of the S segment to the S waves to the starting of the T wave, that is called ST segment. And QT interval from the starting of Q to the end of T waves. Another wave is a U wave. Details I will be in the next lecture, so I will not go. So P wave is created basically by the depolarization of the atria, and depolarization of ventricles causes QRS complex. T waves by repolarization of the ventricles. Waveforms occurs repeating rhythms, that is called sinus rhythm. Basically it is called sinus rhythm because it originates from the sinus node. Fourth wave, U wave, which is seen in many people. It is commonly seen even in the normal people, V2 and V3. Some authors say it is due to the late stage of ventricular repolarization. Some say it is described as a post-repolation phenomenon, but most commonly you can see in the hypokalemia. So main important thing here is electrical vectors, that is how P wave and QRS complex are seen in the EC tracing. First vector is generated by atria, which will deposit P wave in the ECG tracing. Here you can see once the action from SA nodes, once the action potential or starts electric impulse, it will first depolarize right atrium, which you can see in V1, because here V1 is right atrium faces to V1, or V1 faces to right atrium. Here we can see a positive waves, and once right atrium is fully depolarized, it start depolarizing left atrium, which you can see as a negative, because V5 is left atrium is away from V1. So it happens opposite here. V5, this initial part is the right atrium depolarization. This next part is a depolarization of the left atrium, and vector of the P wave is plus 40, that is, it is all it is directed to the second leg. Then coming to the ventricle vectors, that are, it is from second, third and fourth. Depolarization ventricle generates 3 large vectors, which leads to 3 waves in the QRS complex. Second vector, it is from the interventricular septum. Depolarization of interventricular septum proceeds from the left side to the right side. This is what I was speaking. And IVS vector is too small due to the relatively small size of interventricular septum size. IVS septum, see V1 is here, so from left to right, when it starts electric impulse, here we can see a positive wave on V1, which we are seeing here a small wave. As the impulse is small, we can see a small R wave. In V5 you can see here is a V5 which is directed to the left ventricle, so here you can see a negative wave here, because the vector is going away from the V5. So here you will see negative, which is called as Q wave. So third vector, which is from the ventricular free wall, this one green color arrow, vector results from the activation of ventricular free wall, and directed from left and downward. Vector from RV doesn't comes into expression because it is too small, and it is masked, or you can say drowned by the large LV vector. Vector of the ventricular free wall is mostly generated by left ventricle. Activation proceeds from endocardium to epicardium. Here again you can see V1. As the ventricular free wall vector goes away from the V1, you will see a negative wave here, which you are seeing as a S waves. And as it is going towards the V5, you are seeing a positive wave, that is R wave. Fourth vector, it is from the base of ventricles. This is directed backward and upward, heads away from the V5, which electrodes is S wave. Lead V1 does not reflect this vector, only you can see in a lead 5. So in short, I will just go through the heart axis. Basically, it will be covered in the next topic. Heart axis, normal axis is minus 30 to 90. Basically, some books say it is minus 30 to 100, but for practical purpose, they have taken from minus 30 to 90. This is right axis, 90 to 180. Extreme left axis, it is minus 90 to 180, and left axis minus 90 to minus 30 to minus 90. So conductivity of the heart. See, this is heart where SA node you can see here in a right atrium at the junction of the inferior cava and the right atrium. This is AV node, which is inferior septal area of the right atrium, and you can see a bundle of His here, and this is right bundle branch, left bundle branch. You may thinking why he has taken a 2 diagram. Basically here it is left anterior fascicle and posterior fascicle is not differentiated, so I taken another. This is left anterior fascicle and this is left posterior fascicle. So again the same electrical cells. Basically heart has 3 types of the cells. One is a fibrous type of cell, which consists of walls and muscle. Then another is contractile cells, they are myocytes, and main is electrical cells, where this SA node, all these things are. Electrical cells of the heart are arranged in conduct system that carries electric impulse to every part of the organ. Conduct system consists of SA node, AV node, bundle of His, left and right branch, and Purkinje fibers. So SA node, what I told, it is a small patch of electric cells present at the located at the right atrium near junction with the superior vena cava. SA node acts as a primary pacemaker because it has a fastest rate of depolarization. Once it slows down or fails, the next fastest pacemaker takes over, that we can say as a escape beats. Electric impulse spread from SA node to both atria, causing the atrial myocyte to depolarize. AV node impulse from SA node goes to AV node, which is located at the inferoseptal right atrium. Conduction from AV node is 10 times slower than the surrounding muscles. This slowing of conduction allows the atria to finish the contracting before the impulses to the ventricle. Otherwise, both will contract one time and the blood will not go out. Slow conduction to the AV node also limits how many beats per minute the nodes can conduct. This is useful in atrial fibrillation, because in atrial fibrillation the heart beats around more than 181, so means more than 150, then that time only few of the beats are conducted to ventricle. So bundle of His, electric impulse enters to bundle of His from the AV node. Bundle of His penetrates the atrial wall and enters the interval septum. It crosses the fibrous layer that separates atrial and ventricle. AV node and bundle of His is the only route of electrical conduction from the atria to normal ventricle. Left and right bundle branch, you know, it carries the electric impulse in left and right ventricle. Left bundle branch divides again into right anterior and posterior fascicle. Purkinje fibers are the branching network Purkinje fibers that carry electric impulse every part of the ventricles almost simultaneously, ensuring rapid and effective contraction. Conduction from the His Purkinje is extremely rapid and faster than the muscles of the ventricles. So this is just a style. SA node, it is 60 to 100 beats per minute. This is a deploy rate. AV node 40 to 60 beats per minute. His Purkinje is 20 to 40 beats. Just take home message. I thought I'll just tell because everything is important. So you can see PO is represented by atrial depolarization, QRS is ventricular depolarization, and TO is ventricular depolarization. And this already I discussed. Thank you. Before closing, I once again like to thank all organizing committee for giving me opportunity and all the delegates for peaceful listening, and welcome all delegates. Thank you.
Thank you so much, sir. This was indeed a very simple yet very illustrative explanation. I request Dr. Godse to felicitate Dr. Karpe, sir, with a token of appreciation. Thank you so much, sir.
So this is for all the residents and the students. If any doubts regarding the ECG basics, please ask the questions.
I request Dr. Karimungi, sir, as well to felicitate Dr. Karpe. I request the chairpersons to wait on the dais for the next session. So our next session is by Dr. Rahul Somani, sir, who is an interventional cardiologist at Shri Markandeya Solapur Cooperative Hospital and Research Center. And his topic is normal ECG and its variations.
Good evening, everybody. Thanks, Dr. Kedar, for giving nice lecture or nice discussion on a basic technical aspect of ECG and anatomy and physiology of conducting system of the heart. I will take next your 15 minutes in basics of ECG, normal ECG and its variation. This topic is very important because you know the normal ECG, then you come to know the abnormality of ECG, which we'll see next 2 days. See, ECG is nothing but the electrical activity of the heart, and it is called as electrocardiogram. The machine is called as electrocardiograph, and the procedure of ECG doing is called as electrocardiography. As you know, most of the students or everybody, normal ECG has basically 5 waves and 2 segments. This is the ECG. See, this is the isoelectric line. Anything above this is supposed to be the positive wave, and anything below this line is called as negative wave or negative deflection. Already little bit covered by Dr. Kedar. So we will see each and every part of this normal ECG and their normal magnitudes. It has 2 axes. Horizontal is x-axis, vertical is y-axis. Horizontally it is duration, and vertically it is amplitude. See, this is the P wave. First positive deflection, the P wave. The first positive deflection is in the ECG is P wave. It is due to the atrial depolarization. The normal duration on horizontal axis is 2 to 2.5 millimeter or 80 to 100 milliseconds, because 1 millimeter equal to horizontally 40 seconds. Second is amplitude. vertically P wave is again 2 to 2.5 millimeter vertical or 0.2 to 0.25 millivolt, because 10 millivolt equal to 10 millimeter equal to 1 volt. P wave is normally rounded and symmetrical, and best P wave seen in standard limlit 2. In V1, the P wave is normally biphasic. It has two components. First is positive component and second is negative component in V1. This is because the P wave is because of atrial contraction and atrial depolarization, and the SA node is located in the right atrium. That's why the first is the right atrium get activated or depolarized, and then left atrium get activated. That's why the first positive deflection in lead V1 is because of right atrial contraction or depolarization. It is positive deflection. It is normally less than 0.15 millivolt, means less than 1.5 smallest square. It is the first positive deflection of the P wave in lead V1 because of right atrial contraction. The negative wave is second component is below the line, and this is because of the left atrial contraction. Normally it is less than 0.1 millivolt, means normally less than 1 smallest square. This means in V1, P wave is biphasic. The first component is because of right atrial contraction. Second is left atrial contraction. Why left atrium is negative? Because the left atrium and it is get late activated because SA node is located in the right atrium. Second thing, normally the left atrium is posterior to the right atrium. That's why posterior and slightly inferior to the right atrium. That's why the second component of the P wave because of left atrial contraction is negative normally. Then we should do QRS complex. See, the P wave is because of atrial depolarization. There is no wave of atrial repolarization seen in 12 lead surface ECG. This is because the P wave is because of atrial depolarization, QRS is because of ventricular depolarization, and T wave is because of ventricular repolarization on surface ECG. But there is no lead of atrial repolarization seen in surface ECG. This is because this is merged in the QRS complex in surface ECG, what we are doing routinely. That's why there is no wave of atrial repolarization in 12 lead surface ECG. QRS complex. This is QRS complex. This is Q wave. This is from here to here is R wave, and this is the S wave. This is Q, this is R, this is S. What is Q wave in QRS complex? The first negative deflection of the QRS complex is Q wave. Negative means below the line, positive means above the isoelectric line. The first positive deflection of the QRS complex is R wave. And the first negative deflection in QRS complex after the R wave is the S wave. Means this is first negative complexion or below the line or negative deflection is the Q wave. The first positive QRS wave is R wave, and the first negative after the R wave is always S wave. This could not be Q wave because this is the first negative wave after the R wave. That's why it is a S wave, which could not be, both are negative waves. Sometimes Q wave is normally not seen also. That's why this is always S wave, not Q wave, because this is after the R wave. The first negative wave of QRS complex is Q wave, positive is R, and the first negative wave after the R wave is always S wave. This is the basic you should know. This is the QRS complex. R wave, due to the QRS complex is due to ventricular depolarization. Normal values duration is QRS 50 to 110 milliseconds, means 2 to 3 millimeter horizontally duration. The voltage of QRS complex, we cannot tell normal values, but generally voltage of QRS complex more than 5 millimeter in standard limb leads and more than 10 millimeter in precordial leads is normally. If the QRS complex less than 5 millimeter in standard limb leads and less than 10 millimeter in precordial leads, then it is called as low voltage ECG. What is the exact duration, exact amplitude of QRS duration? We cannot predict. This is because the QRS amplitude voltage varies depending on various things. First, electrical force generated by the ventricular myocardium. If patient has myocardium defect or acute myocardial infarction or ventricular dysfunction, dilated cardiomyopathy, then the ventricular contraction will be weak, and that's why the voltage will be QRS complex is less in this patient. Second, the amplitude depends upon the distance of the electrode from the ventricles. Precordial leads are on the chest leads. These are very close to the heart. That's why, and limb leads are away from the heart. That's why normally QRS voltage amplitude is more in precordial leads as compared to the limb leads, because leads are more close to the heart. body build. Normally average thin person will have high amplitude and obese person will have low amplitude because distance between the lead and the heart will more. QRS axis, normally QRS axis 50 to 60. So QRS will be highest in lead, QRS amplitude highest will be seen in lead 2 as same as P wave. This is because the axis will be more, positive axis will be more into the lead 2. However, as the age advances, normally the axis will shift to the left and the amplitude of QRS amplitude will be more in lead 1 and AVL in older patients as compared to the young patients. So, these variable things will show you different amplitude of QRS complex. There is no standard definition of QRS voltage, but low amplitude voltage you should know 5 mm and 10 mm. After QRS wave, we will see the T wave in ECG. This T wave is because of, T wave is always in the same direction of the QRS wave, QRS complex. The T wave is because of ventricular repolarization. Normal duration and amplitude is same as P wave, T wave, horizontally 2 to 2.5 mm or 80 to 120 millisecond or 100 millisecond, amplitude vertically 2 to 2.5 mm. However, the T wave is more blunted and asymmetrical as compared to the P wave normally. P wave is normally more symmetrical, T wave is asymmetrical and more blunted. Like QRS complex, its exact dimension we cannot tell because of it depends upon various things. U wave. Normally wave sometimes seen, best seen in the mid precordial leads V2 to V4. Not seen in, U wave is never seen in the limb leads. The exact cause of genesis of U is controversial, but most commonly seen in hypokalemic abnormal things, but sometimes it may be seen in normal. Now after completing 5 waves and U wave, we will see segments. The PR segment. The PR segment is from the onset of P wave to the onset of QRS complex. Normal duration is 0.12 to 0.20 seconds, means 3 to 5 smallest squares horizontally. ST segment from the end of the S wave to the beginning of T wave. Remember, ST segment is from the end of the S wave to the beginning of T wave, but PR segment includes the P wave in that segment because it's from the onset of P wave to the onset of QRS complex. ST segment exactly it is not isolated, it little bit upgoing normally. See, this is what we have seen. This is PR segment. This is PR segment. From here, onset of P wave to the onset of QRS complex. This is ST segment from the end of S wave to the beginning of T wave. This is QT interval and this is the QRS complex. Heart rate. Normal sinus rhythm heart rate is 60 to 100 per minute. How you calculate the heart rate on ECG in sinus rhythm? If patient is sinus rhythm, then you come, there is two methods. 1500 divided by smallest squares in 2 consecutive RR interval when there is heart is regular sinus rhythm, or 300 divided by number of 5 mm squares in 2 consecutive RR interval. Rhythm, normal rhythm is always regular and it is sinus rhythm, always P wave is seen in normal ECG. Some normal findings. This, if you know the normal, then you come to the abnormal. QRS voltage highest seen in lead 2. All waves are inverted normally in AVR because AVR axis. Normally all lead P, R, T are positive, Q and S are negative. But in AVR, opposite to this is always normal. Means P, R, T negative and Q, S are positive. This is because the QRS axis is seen opposite or inverted as compared to other leads, AVR positive lead. As you go from V1 to V2, V2 to V3, V2 to V in ECG, normally R wave amplitude will increase and S wave amplitude will decrease. Except in V5, always remember in normally when you go V1 to V2, R amplitude will increase, normally S will decrease. V2 to V3, R is more than V2 in lead V3 and S will decrease. But in R wave is always normally bigger in V5 as compared to V6. Here is exception. If R wave is more in V6 as compared to V5, it is one of the criteria for left ventricular hypertrophy. Q wave, regarding the Q wave. Sometimes Q wave is normally seen, most of the time it is pathological. What is the normal Q wave? Small q in one AVL V5 V6 or left leads normally seen but it is always, normal Q wave is less than 30 millisecond in duration, means less than smallest square in duration horizontally, and less than 0.05 in amplitude, means less depth is always small, half of the smallest square. This is normal QRS. Some authors are telling normal Q wave or pathological Q wave more than 25% of the amplitude of the R wave in the same that lead. If it is less than that, it is normal. If it is Q wave amplitude or depth is more than 25% of the R wave amplitude in the same lead, it is pathological. This is we have seen ECG. This is standardization, 25 millimeter per second. You have to see 10 millimeter forward. See, AVR is normally negative. Always PRT is negative. As you go from V1 to V2, R wave increases. Yes, R wave increases, S wave decreases. But see, here exception. R is bigger in V5 as compared to V6. Up till now, here is R is decreasing, here is bigger. It otherwise, if R is here big and R is small, it is LVH. Normal variations. See, up till now we see normal ECG. Now these abnormalities are seen, but these are normally seen. That's why it is a normal variations of ECG. Persistent juvenile pattern. What we discussed, T wave is normally in the same direction of QRS, and it is always positive except AVR. But T wave inversion is common in V1 to V4 in infants and children. It is normally in infants and children, it is T wave inversion V1 to V4. It is called a juvenile pattern. But if it persists in adulthood, it is called as persistent juvenile pattern, and it's sometimes seen as a normal variation in young adults. T wave inversion V1 to V4. See, this is a T wave. Actually, this is a 7-year lady, girl, but this is normal for her, juvenile pattern. But if this persists T wave inversion in adult, it is also called as persistent juvenile pattern. It is normal variation. Second normal variation is early repolarization syndrome. This is also you should know because it mimics acute AMI, and you should know the history of the patient, chest pain, age of the patient, risk for the acute AMI. Then you come to the early repolarization syndrome. What is early repolarization syndrome? Prominent J wave. J wave means junction of the S wave, end of the S wave and beginning of the ST segment is the J wave. The early repolarization, prominent J wave, concavity and minimally upward ST segment like pericardial effusion. Tall and symmetrical T waves, sometimes T wave are inverted, prominent and narrow Q wave in the left precordial leads, tall R wave in left precordial leads, prominent U waves and sinus bradycardia. These are the points for early repolarization syndrome. Sometimes it's seen in acute young patients. See, this is the ECG of early repolarization syndrome. See, this is minimal ST elevation, concavity upwards in V4. Here also ST elevation is seen. This is a young patient, ST elevation in V4 to V5. Tall T waves, R wave, and he is not sinus bradycardia, but is a tall T waves, ST segment minimally concavity upwards. Though initially thought it is a benign condition, but sometimes these patients of early repolarization syndrome has risk for sudden cardiac death. Third normal variation is non-specific T wave inversion. These are although we call as non-specific STT changes. The causes of non-specific T wave inversion is anxiety, orthostatic hypotension, postprandial response, hyperventilation, and no apparent reason. T wave inversion is seen. Last 2 slides, please. Right axis in infants and childhood is normal. This is normal variation in infants and childhood, right axis deviation. RBBB can be seen in 7% of the general population normally. RBBB is 7% is normally seen. LBBB is more hazardous than RBBB. LBBB may be seen normally, but the patient who has LBBB in future going to dilated cardiomyopathy are more. RBBB is normally seen 7. Sinus arrhythmia. Most of the time reference come from the physician or from this irregular heart rate. See, what is sinus arrhythmia? It is normally seen. Normally heart rate decreases on inspiration and increases on expiration. That's why if patient is taking deep inspiration during ECG, there will be some variation in abnormality, but P wave is always seen there. So normally heart rate will decreases in inspiration, increases expiration. This is called a sinus arrhythmia, sometimes in seen ECG. Low voltage ECG in obese and high voltage ECG in thin individuals also normal. Regarding Q wave, very interesting. I told you the normal values of Q wave, amplitude is less than 0.05 and duration is less than 0.30. One I want to tell you, Q wave of, this is the definition of normal Q wave, small, less than 0.5 millimeter in depth and less than 1 millimeter square in duration. But isolated Q wave in 2-3 AVF is the old inferior myocardial infarction. But Q wave of any depth, more than 3 millimeter, 4 millimeter, only in lead 3, it will not old AWMI. lead 2 and AVF will not show Q wave. Only lead 3 will show Q wave. Most of the patient or physician told this is old IWMI. It is not old IWMI. Isolated Q wave of any depth in isolated lead 3 is not pathological. Sometimes T wave inversion lead 3 V1 is normal, and if the patient has tremor, Parkinsonism, the ECG shows irregular rhythm, we can tell it is an artifact or it is a AF. This is the ECG of isolated Q wave inversion lead 3 only. See, lead 2 is normal, no Q wave insignificant. Lead AF, no. But it is more than depth, more millimeter, but it is not pathological because only lead 3 shows Q wave. Thank you.
So please wait on the dais. I request Dr. Godse and Dr. Karimungi to felicitate Dr. Somani with a token of appreciation. A round of applause by the audience, please. A very informative session about summary of ECG variations by Dr. Somani. So, before plunging into the depths of ECG, we needed to know what are the basics of normal ECG. Now we move on to what are the abnormalities which can be seen in the ECG. So, yeah, Dr. Parle wants to make an announcement.
This is announcement for the quiz. Those who have cleared online quiz and have been awarded complimentary registration, they are requested to gather outside the Medtronic stall and they are requested to form their own teams. As a special gesture, the organizing committee has decided to increase 4 more contestants to the quiz. The preference will be given to those who have participated in the online quiz. So, I presume the medicine residents, there will be 20 who are given the complimentary registration. So, those 20 and 4 more. So, I request all of them to gather outside Medtronic stall and form their teams. Thank you.
So, I request our next chairpersons for the session, Dr. Shrikant Page, who is a senior physician at Markandeya Hospital, and Dr. Deepak Gaikwad, who is a senior cardiologist at Raghoji Hospital, to come on the dais. And our next speakers for the session would be Dr. Shailesh Patil, who will be speaking on ECG artifacts. Dr. Patil is a senior cardiologist at Rudayam Super Speciality Hospital and Ashwini Sahkari Rugnalaya and Ashwini Rural Medical College.
Good evening, ladies and gentlemen. I welcome you all for this wonderful ICCon 2023 Solapur conference. So, after looking at the normal physiology and normal duration of ECGs, so I'll be telling you few minutes of ECG artifacts. What are ECG artifacts? ECG artifacts are electrocardiographic alterations, means abnormality in the ECG, but in the absence of cardiac electrical activity. Means these are alterations are not produced due to heart, they are due to some other source. As a result of these artifacts, the baseline ECG as well as the waves will be altered, and this might lead to misinterpretation and misdiagnosis. So let me classify this ECG artifacts into 3 subdivisions. One is errors due to standardization, errors due to electrode misplacement, and external and internal artifacts. As we have seen, the normal speed of the ECG lead is 25 millimeter per second, and gain setting is 10 millimeter per millivolt. Depending upon this, we do the proper ECG interpretation. So, if the ECG speed is increased, which normally is 25 millimeters per second, if the speed becomes to 50 millimeter per second, the distance between RR interval will be reduced. How it helps? This is usually done in case of children where there is a normal physiological tachycardia, where the heart rate is 140, 160. There, to properly see the waveforms, we can increase the speed to 50 mm per second. And also in case of tachyarrhythmias, where we are not able to see the proper waves, P wave, Q, R, S, there you can increase the speed to 50, and we can, it will help in the diagnosis of the ECG waveforms. Second is your gain setting. Normally, as we have discussed, it is 10 millimeter per millivolt. You can see there. So one thing is, if you reduce the height, if you do half standardization, that is, if you do to 5 millimeter per millivolt, this is usually done in low voltage QRS complexes where the waveform is not properly seen. That time you can half standardize, and nowadays new machines mention the half standardization on the ECG, or sometimes the ECG technician has to particularly note on the ECG that it is a half standardized ECG where low voltage complex can be properly seen. One is double standardization. Double standardization is 20 millimeter per millivolt. We increase the standardization to double. This is usually seen done in cases of hypertrophy, where there is gross LV hypertrophy. There you double standardize so that the whole QRS complex can be visualized well. Errors due to improper lead placement. Precordial leads, as Dr. Kedar Karpe has already mentioned you, where you have to place the V1 to V6 leads and the limb leads. So if the ECG technician misplaces it, it will lead to ECG alterations. Sometimes the ECG technician puts extra gel on the chest and he puts the precordial leads. That time you can see there will be a single equal QRS complex can be seen in all the precordial leads. You can see V1 to V6, the QRS complexes are of same height. This is because single gel, and it calculates the mean potential, and that's why ECG looks like that. Here you can see there is a misplacement of precordial V1 to V3 leads. There is reversal. He has placed the V3 lead electrode on the V1 side and V1 electrode on the V3 side. So ECG abnormality, you can see the V1, there is a tall R wave and it gradually reduced up to V3. And V3, there is a reverse. So this is due to V1 to V1, V3 reversal. If the limb leads are reversed, most common limb lead reversal is right arm, left arm reversal. It's commonly seen in our casualty as well as ICU, where the technician puts the right RA lead to left arm and LA lead to right arm. So this is left. First is the LA RA reversal ECG. What happens, the most important thing we have to see is lead 1 and lead AV R. We have seen that lead 1, there is a positive P wave, positive QRS and positive T wave. In AVR, it should be negative P wave, negative QRS. This is a normal ECG. But in LA-RA reversal of this occurs. Lead 1 will show negative P wave and negative QRS, and lead AVR will show positive P wave and positive QRS. But this same condition can also be seen in dextrocardia. Dextrocardia, you know, heart will be directed towards the right side. There also same thing, the AVR will be positive, lead 1 will be negative, but the main difference is your precordial leads. In LA-RA reversal, 1 will be negative, AVR will be positive, but the precordial leads will show normal R wave progression. That is, as we go from V1 to V6, there will be R wave increase amplitude and S wave will decrease. But in dextrocardia, as the heart is situated to the right side, there will be inverse R wave progression. Means there will be R wave prominent in V1, V2, which will gradually disappear till V6, and S wave will gradually reappear in V6. This is very important differentiating point between LA-RA reversal and dextrocardia. Also few points about dextrocardia, where there is AVF lead is not affected, and rest things I have already discussed you. Now coming to artifacts due to other external source. One is external artifacts Due to the electric current source, sometimes ECG alterations can be seen because of external current source. The first ECG, figure 2, you can see there is electrical, you can see the ECG abnormality due to external electric source. Second thing is figure 3, offset potential is not seen nowadays, new machines. It was seen in older machines due to stainless steel electrode material was used. Nowadays, chloride, silver chloride is used, that's why this offset is not seen nowadays. Third is your electrode movement due to excess fluid or gel. It's called a wandering baseline. Means the baseline will be wandering, it's moving. And fourth thing is flat line artifact. Due to lead, if there is poor contact with the electrodes and the lead, if the pin is loose, that time you may have this flat line ECG and you may think that patient is arrested, there is no cardiac activity. But first you have to check the proper connections are there with the electrode, with the pin, and then only you can come to a conclusion. Internal artifacts may be due to either epidermis or muscle contractions. Muscle signals can sometimes produce fluctuation in the ECG. And second ECG, you can see that is due to from the epidermis. Signals are received in the ECG from the epidermis. This is a classic cases in Parkinsonism patients where due to tremors, you see alterations in the ECG and you misdiagnose this as a atrial flutter. So in such cases, you have to apply the electrodes, limb leads proximally, upper level. Then you can reduce this pseudo-atrial flutter waves. This is a very important ECG because if you misdiagnose VT, it is very dangerous for the patient. See, very important to, this is a case of pseudoventricular tachycardia. Why it is pseudoventricular tachycardia? Because you see in lead 2, 3, there are changes, and lead 1 as well as precordial leads, there is no arrhythmia changes. So it is a very important thing to differentiate from ventricular tachycardia. Ventricular tachycardia, all the leads will be showing the changes, but here due to tremors, somatic tremors, only few leads are showing the changes. And the other thing is, in ventricular tachycardia, there will be hemodynamic compromise and also unstable baseline in the ECG before or after the event. And this pseudoventricular tachycardia, usually you can see movement of the patient, somatic movements. This is a case of hypothermia. The triad ECG diagnosis of hypothermia is done by a triad, that is a Osborne wave. You can see the deflection in the QRS. Second is bradycardia, and third is tremor artifact. So it's tremor artifact itself is the diagnostic criteria for this hypothermia. So proper knowledge of the ECG is important, and also proper how to take a proper ECG, that's equally important. Thank you.
Thank you so much, Dr. Patil. I request Dr. Shrikant Page and Dr. Gayakwad sir to felicitate Dr. Patil with a token of appreciation. A round of applause by the audience, please. Thank you so much, sir. Our next speaker would be Dr. Amjad Sayyed, who is an interventional cardiologist at Noble Hospital, Solapur. He would be speaking on the topic of atrial arrhythmias, narrow QRS tachycardia.
Good evening, everybody. My topic is narrow QRS tachycardia. Though it's a very broad topic, I'll be dealing with the salient features of this tachycardia. Basically, by definition, a narrow QRS complex is less than 120 millisecond. And the origin of this arrhythmia is generally above the ventricle, that is bundle of His, sinus node, or AV node, or some combination. There are a few wide QRS tachycardia which are supraventricular. It is generally due to aberrancy or pre-existing rate-related aberrancy. The arrhythmia description generally starts with the rate, rhythm, origin of impulse, pulse conduction, ventricular rate, and special phenomena like pre-excitation should be seen in a ECG and other findings. So there are a few terminologies I need to explain. Is paroxysmal. Paroxysmal is intermittent, start and stop, and generally have a regular ventricular response, and it is sustained more than 30 seconds. These features are characteristics of AVRT and less frequently atrial tachycardias. Incessant supraventricular tachycardia is unlikely to spontaneously terminate. There are a few supraventricular tachycardias which are not considered as PSVTs like atrial fibrillation, flutter, and some irregular arrhythmias. The prevalence of this PSVT, that is paroxysmal supraventricular tachycardia, is generally similar in male and female. But recently in 2018, one study from UK suggests that it is more common, especially in males after age of 65. The major causes or major incidence of these types of supraventricular tachycardia is maximum is AV and RT, 60%, AVRT 30%, and atrial tachycardias and sinoatrial nodal reentrant tachycardia 10% of the cases. Very rare causes are junctional tachycardias or non-paroxysmal junction tachycardias in adult and jet in children. And we see multiple brief runs of SVTs on Holter are generally due to atrial tachycardias. So the classification of narrow QRS tachycardia is if the atrial tissue is the origin, sinus tachycardia, inappropriate sinus tachycardia, atrial nodal reentrant tachycardia, intra-atrial reentrant tachycardia, atrial tachycardia, multifocal atrial tachycardia, and atrial fibrillation and flutter. AV junction, the common is AV and RT, or AVRT, atrioventricular reentrant tachycardia, junctional tachycardia, or junctional ectopic tachycardia in children, or non-paroxysmal junction tachycardia in adult. If you see the pathogenesis, the mechanism of re-entry is the commonest form, and that requires two different tissues of different electrophysiological properties which are linked proximally and distally, anatomical or functional linking, and they form a circuit, and that is a re-entry. And it depends on the excitability of the tissue and gap and other things. But the other mechanisms are also seen in arrhythmias like enhanced automaticity or abnormal automaticity. And very few tachycardias have triggered activity as a mechanism of arrhythmia. The commonest being digitalis toxicity or post-MI or ischemic cardiomyopathies. The clinical manifestation of this supraventricular tachycardia is variable depending on the heart rate, blood pressure, tissue perfusion, or underlying comorbid cardiac conditions, or some patients have more sensitive for these symptoms. The commonest symptom being palpitation, syncope, presyncope, or diaphoresis, chest pain, shortness of breath, and a classical increased micturition after episode of supraventricular tachycardia has been described. The physiological sinus tachycardia is appropriate. It is appropriate response for the physiological sympathetic increased tone, but there is something called inappropriate response. The heart rate is more than 100 or average more than 90 for 24 hours without any physiological response. That is called inappropriate sinus tachycardia. It is difficult to differentiate from sinus tachycardia. Only while we see the transition from this thing on ECG wise we can diagnose. The commonest treatment is either a beta blocker or funny channel blockers like ivabradine is used. The atrial tachycardia is one of the common tachycardia that is called focal atrial tachycardia. This having a characteristic focus in the atria and organized atrial activity, discrete P waves and a baseline between two P waves. Irregularity is generally not seen, but as a warm-up or warm-down phenomenon, you may see some irregularities. And usually the rate is 140 to 220. The atrial tachycardia origin can be diagnosed by the surface ECG, especially in V1. Lead V1, if you see a P wave is negative or biphasic positive, generally it is arising from the right atrium. If lead V1, the P wave is positive or biphasic negative, it is arising from left atrium. Here is the ECG. The left side ECG is atrial tachycardia, which is arising from the pulmonary vein, that is left atrial tachycardia. You see the V1 in tachycardia tracing, the P wave is positive. So it is a left atrial tachycardia. And the right side ECG is tachycardia arising from the crista terminalis, that is a right atrium, in which you see the biphasic P wave, which is positive in V1. So you can even on surface ECG sometimes some clues to diagnose this. This is the incidence like how the arises. Most commonly, atrial tachycardia arises from right atrium, almost 70%, and left atrium, almost 30%. The left atrium side is most common nowadays. We know it is arising from the pulmonary veins. So the ablation of these veins leads to, can get rid of these arrhythmias. The multifocal atrial tachycardia, that is chaotic rhythm, is by definition more than 100 per minute heart rate, and there are more than 3 different morphologies of P waves. If the heart rate is not more than 100, then it is called a wandering pacemaker. The distinction between the two is because of the clinical presentation. If you see the left side ECG, it shows classic multifocal atrial tachycardia that is MAT, seen in severely decompensated pulmonary disease, elderly patients or post-operative patients, and generally hemodynamic compromise is not there. And there are different forms or forms of P waves morphology and irregularities in the heart rate. Right side you can see the wandering tachycardia, wandering pacemaker in which the heart rate is less than 100, but the P wave morphologies are different in different QRS complex. Then sinus node reentrant tachycardia, a specific type of atrial tachycardia is due to micro reentry or abrupt onset and termination. The reentry is in sinus node in itself. If you see the ECG in the baseline, the fourth wave is ectopic atrial activity, which leads to ultimately forms the last few complexes are sinus node reentrant tachycardia. You see the P waves are similar in sinus as well as in tachycardia. So it is difficult to differentiate once it starts. If you happen to see it while starting, probably you may be able to see that. Atrial fibrillation, I'm not going to detail, which is not part of much of a supraventricular tachycardia. Of course, atrial fibrillation is very common. Because of ineffective atrial contraction, there is a loss of ejection fraction, and if underlying pathology is there, then it is a difficult arrhythmia to manage, but it's very common. What are the salient features are RR variability, absent of P waves, or fibrillatory waves are present. Flutter. Flutter have different types. It is divided into cavato-tricuspid isthmus-dependent flutter. That is, in that again there are 2 types. That's a typical, that is counterclockwise. The substrate is tricuspid annulus, and superiorly this inferior septum and the right atrium. So it goes counterclockwise and is most common. So it produces negative waves, P waves, that is flutter waves in 2,3 AVF. And if there is something called reverse, I'll probably show the diagrams better. Yeah, this is better. So you see the left side, there's a typical flutter. You see the sawtooth appearance in the 2,3 AVF because it's counterclockwise around the tricuspid annulus. And you see the right side is a reverse typical flutter, which happens to the counterclockwise, and the P waves are positive, that is flutter waves are positive in 2,3 AVF. There is something called cavato-tricuspid isthmus dependent flutter. This flutter starts from any right or left atrium, or generally from the scars of these atrias, or any insult to the atria in the past, incisional and all those things, and some junctional tachycardia also. The classic ECG is like flutter waves are neither sawtooth or not very positive in 2,3 AVF. You see the subtle flutter waves are seen, and the rate are generally lower side. The treatment, if you see the atrial fibrillation, we're not going to the detail of treatment, of course, but only thing is irregular arrhythmias. Multifocal atrial tachycardia doesn't require anticoagulation because the AV synchrony is maintained and doesn't require much of treatment. But against that, atrial fibrillation and flutter requires definitive treatment because either a rate control or rhythm control. Of course, rhythm control will be ideal, but after long multiple trials and different meta-analysis, it is not settled which is better. But a rule of thumb, if it is an acute situation of atrial flutter or fibrillation, probably rhythm control is achieved and is better done. If it is a chronic situation of flutter and fibrillation, probably getting control the rhythm is difficult. And if you try more with the drugs, you'll end up in drug toxicity. Or if at all, you require a rhythm control in a chronic situation, probably the newer modalities like ablations of pulmonary veins or catheter ablation of atrial fibrillation should be attempted. The atrioventricular reentrant tachycardia. This type of AV node itself inside have a micro pathways like fast pathway, slow pathway, or a variant pathway which is involved in slow AV and RT. So typical AV and RT has a slow fast pathway, atypical has a fast slow pathway, and another tachycardia is called slow pathway. So if you see the diagram, the long RP tachycardia is usually atypical AV and RT. A typical AV and RT was a short RP tachycardia. So it goes from slow to fast, slow-fast pathway. This is the tracing of ECG. Same, both are AV and RT. If you see the P waves in the left side ECG, there is a blip that is a pseudo R wave is seen. It's a short RP tachycardia. But sometimes, if similarly, there is a AV and RT on the right side, it is totally superimposed. The P waves are not seen at all. So sometimes you may be able to diagnose or may not be able to diagnose. It is generally because of retrograde P waves, the slower heart rate. Sometime in short RP tachycardia, you will be able to see the pseudo R wave in PSVT of AV and RT. The next is atrioventricular reentrant tachycardia, that is accessory pathways. This is a pathway between atria and ventricle, accessory pathway which conducts very fast. It bypasses the AV groove. And according to these are classified according to the location of the pathway or according to the conduction properties like decremental or non-decremental pathways, antigrade or retrograde conducting pathways. Accessory pathways are other types like lower side atriovesicular pathways, nodovesicular pathway, nodoventricular pathways, or fasciculoventricular pathways are also noted like Mahim's pathway and all. Manifest pathway is a terminology used when baseline ECG you see the classic pathway WPW syndrome ECG, that is called manifest pathway. Concealed pathways are ECGs are normal. They conduct only retrogradely. So during arrhythmias only you can come to know that is they are retrograde conducting pathways. So pre-excitation of the ventricle happens from the alternative pathways. So what are the ECG findings? If you see the baseline, this thing, it depends on the relative contribution from the ventricular activation by normal AV node and the pathway. And the degree of variable degree, if you see this diagram, you see the delta waves. So the presence of delta waves is like there is a blip, there is a deformation of the QRS complex when the pathway is conducting. And from the just a small delta wave blip to the whole broadening of the QRS complex is seen when the baseline ECG is pre-excited. And according to this size and the duration and the morphology, even you can localize the pathways. Where is the pathway? Asymptomatic pre-excitation is a terminology in which you see the baseline ECG, there is a WPW ECG, but there is no tachycardia. WPW syndrome is a terminology used when there is a symptomatic documented tachycardia is present, then we call it a WPW syndrome. Why this terminology is important? Because of therapeutic implications. When there is a WPW syndrome, probably we need to ablate the pathway and permanently treat it. But asymptomatic pre-excitation, you need not treat it unless there are high-risk individuals. The pathway conducts in the two main forms like orthodromic AVRT or antidromic AVRT. I can explain this with orthodromic, which is more common. So in this orthodromic means anterior conduction, the tachycardia, the impulse will come from the AV node. So you see the narrow QRSs. But whenever there is antidromic conduction, if the antegrade conduction of the impulse, final impulse is from the pathway, then you see the broad complex. I see the natural ECG of these two situations. You see the left side there is a antidromic and orthodromic, and right side is the antidromic pre-excited supraventricular tachycardias. So right side looks very dangerous. Sometimes if that may degenerate into ventricular fibrillation. Such patients are generally unstable and require cardioversion. What is the junctional tachycardia? It is not very rare, arising within the AV node itself. In children, it is called junctional ectopic tachycardias. It is generally underlying heart diseases, and these are sometimes insistent and leads to cardiomyopathies. In adults, it is seen in myocardial infarction or digitalis toxicity. Arterial activity during the tachycardia is variable. This is the example of junctional ectopic tachycardia. If you see the ventricular rate increases, the loss of AV synchronity, decreased cardiac output, such patients require immediate treatment. So how to evaluate the narrow QRS tachycardia? Basically, first the patient arrives, the hemodynamic stability is the key factor how to proceed with that. If the patient is hemodynamically stable or even unstable, probably ECG gives the better clue. So both things should be considered. If the patient have narrow complex tachycardia is unstable, like signs of serious symptoms, hypotension, shortness of breath, chest pain, shock, these patients immediately need attention, quickly attempt to determine if the rhythm is sinus or not sinus. If it is sinus, then again you can detail evaluate the cause, but if it is not sinus rhythm, cardioversion is the only thing and it is an emergency. So if you see the detailed evaluation of a stable patient, initial evaluation, there is no sign and symptom, then you can go and see whether the patient is stable. Review 12 lead ECG. If irregular rhythm, P waves are absent, atrial fibrillation. If flutter waves are there, it is atrial flutter. If multiple P wave morphologies are there, multifocal atrial tachycardia. If the rhythm is regular, then P waves is detectable. If it is detectable, then go for the detailed evaluation of the P wave, whether morphology of the P wave, relation of the P wave, and P waves, the position of the P wave, that is RP interval. Or if it is P waves are not detectable, and then ventricular rate slows down because of some maneuvers, again you can detect the P waves. If it is not, sometime the arrhythmia itself will terminate, then it is probably AVNRT or AVRT or SNRT. If the P waves are detectable, the atrial rate is more than 250 or greater, it is a flutter. The P waves are identical to sinus P wave, it is sinus node reentrant tachycardia or sinus tachycardia. Abnormal P waves morphology and long RP tachycardias are generally atrial tachycardias, or retrograde P waves in short RP tachycardias are generally most common or common type of AVNRT or AVRT or low atrial tachycardias. If retrograde P waves and long RP intervals are there, uncommon, that is uncommon AVNRT or AVRT with slow pathway, that is PGRT sometime. Abnormal P waves and short RP interval, atrial tachycardia with AV nodal tachycardia. It's 2 minutes, finished. Yeah. So there are different maneuvers you can perform to see this Valsalva maneuver or carotid sinus massage. This can slow down the atrioventricular conduction and atrial conduction and reveal the P waves to becomes easy to diagnose the mechanism of arrhythmias. So intravenous adenosine, it acts on the potassium channel. The doses, we give 6 milligram followed again a shot of 6 milligram or 12 milligram or 18 milligram. These can be tried. Or if you're giving for the central line, 3 milligram should be the maximum dose. So this is the classic example. When you give a carotid sinus massage or adenosine, the arrhythmia is revealed by the flutter waves. So I think it should, yeah, there is a lot of slides. So I'll just show depending on the RP interval, short RP tachycardias, if the RP interval is less than 70 millisecond, it is AVNRT. If it is again short but RP more than 70, it's AVRT or AVNRT or atrial tachycardias. If it is a long RP tachycardia, then it is atrial tachycardia or PGRT or atypical AVNRT. Undetectable P waves, of course, atrial fibrillation or sometimes of junctional tachycardias. So what are the different things we can do to diagnose? Basic is the ECG, or some other tests to find out the abnormalities, or ambulatory monitors like Holters. Stress test sometimes for the pathways we do. Echocardiography and CT scan and other MRI and MRI test for structural abnormality. Arrhythmias with structural abnormality should be treated seriously because they decompensate. Thank you very much.
Thank you so much, Dr. Sayyed, for this extensive. So wait a second on the dais. I would request Dr. Shrikant Page and Dr. Deepak Gaikwad to felicitate Dr. Sayyed for his very extensive and stepwise talk on an extensive topic of atrial arrhythmias. I request all the audience to have a round of applause, please. Thank you so much, sir. There is one announcement. This is an exciting opportunity for all those MD students who have probably missed on the opportunity of participating in the ECG quiz. There are 4 more extra entries which are available. If anyone is interested still, they can contact the Medtronic stall outside as requested by Dr. Parle before as well. Thank you. Now I hand over to Dr. Gandhi to conduct the next 2 sessions.
Thank you, Tanushree. Moving to our next session, I would like to invite Dr. Anita Madam. As chairperson, I would like to invite Dr. Anita Madam and Dr. Kuldeep Kopalwar. Anita Madam is Associate Professor at Dr. VMGMC Solapur. Dr. Kuldeep is cardiologist from Pandharpur. Our next speaker is Dr. Anupam Shah sir, renowned interventional senior cardiologist from Ashwini Hospital. After looking into the atrial arrhythmias, now we are moving towards the ventricular arrhythmia, broad complex QRS tachycardia.
Good evening, everybody. Welcome to ECCon Solapur. It is nice to see such a good gathering for Fellows Workshop. I am sure that we will be having plenty of people tomorrow. Today, my topic is on white QRS complex tachycardia. After an extensive lecture by Dr. Amjad of narrow QRS complex tachycardia, I will be talking briefly about white QRS complex tachycardia. Now, what is the definition of white QRS complex tachycardia? White QRS complex tachycardia, the heart rate is more than 100 milliseconds, 100 beats per minute, and QRS duration is more than 120 milliseconds. That is called as white QRS tachycardia. The first step when the patient comes to casualty and he has white QRS tachycardia, if the patient is unstable without a pulse, this patient should be treated as patient in VF with defibrillation, airway management and drugs. All unstable patients with a pulse, especially if he has hypotension, breathing difficulty, which should be treated as unstable VT. This is very important. Don't waste time in taking a ECG looking for whether it is SVT with aberrancy or ventricular tachycardia, different types of SVT with aberrancy. First step is always you should treat the patient. What are the differential diagnoses of white QRS tachycardia? Ventricular tachycardia is the commonest 80% of the times. SVT with aberrancy is in 15% of the times. Pre-excitation syndrome is in third common. Pacemaker mediated tachycardia, electrolyte imbalance and drugs. Now, white QRS complex tachycardia can be VT broadly or SVT with aberrancy. In SVT with aberrancy, if the patient has underlying bundle branch block and patient develops if the patient has underlying bundle branch block and patient develops ventricular tachycardia, patient will have white QRS complex tachycardia. Next is rate-related aberration. Patients with white QRS tachycardia will be having sinus rhythm, but because of rate, these patients, especially if they have disease of his Purkinje system or they are related to drugs, these patients can have rate-related aberration. And these patients come back to sinus rhythm once the tachycardia is treated. And the third group is pre-excitation syndrome, where what we call as WPW syndrome, where you can have white QRS tachycardia. It can be supraventricular, it can be regular tachycardia or it can be irregular. Irregular can be either atrial fibrillation or atrial flutter. Now, broadly, I will tell you what are the differential points between ventricular tachycardia and supraventricular tachycardia with aberration. Very broad QRS complex, more than 160 milliseconds, always you should think of ventricular tachycardia. If it is less than it should be less than 160 milliseconds, it is SVT with aberration. Here you can see it is more than 4 small squares on this ECG. So this is ventricular, more in favor of ventricular tachycardia. No single sign can be specific to differentiate between ventricular tachycardia and supraventricular tachycardia with aberrancy. There are various points which help us to differentiate, but some of these times we will still not be able to differentiate between these two different group of patients. Second is, if there is presence of AV dissociation, that goes more in favor of ventricular tachycardia. If there is no AV dissociation, that goes in favor of SVT with aberration. Here you can see on this slide, here the P wave is merged on T wave, or you can see here there is P wave which is seen. So there is AV dissociation in this ECG. This favors VT more than SVT with aberrancy. Third is capture beats. What are capture beats? These are the beats which you can see here. This is a capture beat where you can see the sinus beat is seen in between the episode of tachycardia. There, before the SA node is able to SA node is conducting a sinus beat normally here. So this goes more in favor of ventricular tachycardia compared to supraventricular with tachycardia with aberrancy. Fusion beats. In fusion beats are seen in ventricular tachycardia. SVT with aberration, fusion beats are not seen. Fusion beats are hybrid beats. This is a part of before the refractory period. Before the ventricular, you can see this is a hybrid beat. This is a part of ventricular tachycardia and part of sinus beat. These are sinus beats and these are beats related to ventricular tachycardia. So fusion beat again goes more in favor of ventricular tachycardia. Brugada's sign. There are various algorithms which are present to differentiate between ventricular tachycardia and SVT with aberrancy, like Brugada's algorithm or Whelan's criteria. There are so many algorithms which are present, but nothing is specific 100%. So I have compiled all the signs together and I have trying to tell you the basic differences between all the SVT with aberrancy and ventricular tachycardia. Brugada's sign is the QRS duration from the starting of the R wave to the nadir of S wave. This is more than 2.5 squares that suggest more in favor of ventricular tachycardia. Josephson's sign. Josephson's sign is a notch which is present on the nadir of S wave. This notch, if it is present, it favors more of ventricular tachycardia. RSR complex, R capital, S capital, R capital, complexes with a taller left rabbit ear favors ventricular tachycardia. RSR complexes with a taller right rabbit ear favors SVT with aberration. Now you can see here, this is the left rabbit ear. Here you can see the left rabbit ear is taller when compared to the right rabbit ear. That favors more ventricular tachycardia. In this ECG you can see there is a small R wave here and the right rabbit ear is more prominent. This is SVT with aberration. So this is something like a right bundle branch morphology. If you see ECG of right bundle branch block morphology type, that favors SVT with aberration. This RSR complexes with taller left rabbit ear is most specific sign in favor of ventricular tachycardia. Now the 8th point is positive or negative concordance throughout the chest leads. In SVT with aberration you don't see that. What is positive or negative concordance? You see all QRS in only one direction. That favors more of ventricular tachycardia. All QRS are upright in this ECG. You can see in this ECG all QRS are negative. That again goes more in favor of ventricular tachycardia. Absence of typical RBBB or LBBB morphology, that favors ventricular tachycardia. Indeterminate bundle branch block, what we call. In presence of typical RBBB or LBBB morphology, that favors SVT with aberration. Now, if suppose there is a dominant R wave in V1, RBBB like morphology, what are the patterns indicative of ventricular tachycardia? In V1 and V2, smooth monophasic R wave, taller left rabbit ear, a QR complex. And in V6, QS complex, R by S ratio less than 1. These are some signs. Now you can see here there is a smooth monophasic R wave. Tall left rabbit ear, as I had shown you earlier. This is taller left rabbit ear. Now you can see a QR complex. This favors VT. There is a QR complex. When you see SVT with aberrancy, you see RSR pattern. These all are seen in lead V1. These RSR dash patterns suggest SVT with aberrancy. In VT, you get QS complexes. That is not seen in SVT with aberrancy. R by S ratio less than 1, the small R wave, S ratio is bigger. So this favors more of ventricular tachycardia. Now patterns indicative of VT in V1, V2, especially if there is a LBBB type of morphology. Initial R wave more than 30 to 40 milliseconds, Josephson sign RS interval more than 60 to 70 milliseconds. Patterns indicative of VT in V6 is QS complex and QR pattern. Now you can see here, this favors VT, initial R wave more than 30 milliseconds. This is notching and slurring, this is Josephson sign, and see, this is from the starting of the QRS complex to the end of the S complex, more than 70 milliseconds favors VT. In short, if the QRS is more broad, it favors VT compared to SVT with aberrancy. QS complex in VT, QS complexes are seen. In VT, again you see a QR complex. So these favors VT. SVT with LBBB, you see there is no Q waves present in SVT with aberrancy. If Q waves are present, you should suspect that it is more likely to be ventricular tachycardia. Now, we have heard a lecture of axis deviation. If there is extreme axis deviation, northwest axis, that favors ventricular tachycardia. What is northwest axis? You can see here, lead 1 is negative, lead AVF is negative, and AVR is positive. So this is indeterminate axis. This favors ventricular tachycardia compared to SVT with aberrancy. Now, other criteria are if the patient's age is more than 35 years, he has previous structural heart disease, ischemic heart disease, myocardial infarction, congestive heart failure, cardiomyopathy, family history of sudden cardiac death, this all favors VT. If patient's age is less than 35 years, his previous ECG shows bundle branch block pattern with identical morphology on broad QRS complex or WPW syndrome, or patient gives history of relief with vagal ballures in the past, this favors SVT with aberrancy. Now, after knowing all these points, I will show you few of the ECGs which we will try to differentiate between SVT with aberrancy and ventricular tachycardia. Now, this ECG, if you see, there is wide QRS complex. You can see there is irregular heart rate. The heart rate is not seen and no P waves are seen on this ECG. So this is irregular atrial fibrillation and pre-excitation syndrome. So this is WPW syndrome with atrial fibrillation. This ECG shows WPW syndrome with atrial fibrillation. Now this ECG still shows slightly irregular heart rate, but this is not WPW syndrome. You can see the axis is changing. This is more in favor of torsades, and the causes are usually hypokalemia, hypomagnesemia, hypocalcemia, and most of commonly is drugs. Amiodarone is one of the most important drugs which can give rise to torsades. So this is a treatable condition. This needs immediate treatment. Now this ECG, you can see, this ECG shows wide QRS complex. You can see there are tall T waves present, and P wave is seen here. So this is tall tented T waves and wide QRS complex. This is because of hyperkalemia. So another reason of wide QRS complex tachycardia is hyperkalemia. This is typical ECG of hyperkalemia. Now this ECG is from my earlier days when I was doing my post-graduation. You can see this ECG is typical of bidirectional VT. You can see the axis is changing every lead. First beat, third and second and fourth beat are alternate. So this is typical of bidirectional VT, which is seen in digoxin toxicity, commonly seen in digoxin toxicity. Nowadays we don't see because digoxin usage has come down, but this is typical of digoxin toxicity. This is another ECG which is you can see there are no P waves, there are pacemaker spikes. This is pacemaker mediated tachycardia. PMT, the heart rate is more than 130, 140, and you can see the pacemaker spikes are there and there are no P waves. This is pacemaker mediated tachycardia. And now you can see, you feel this is more like wide QRS. This is wide QRS tachycardia, more in favor of SVT with aberrancy, but you can see here, you can see AV dissociation, P waves here. This is more in favor of ventricular tachycardia because of AV dissociation. Thank you.
Thank you, sir. Thank you, sir, for making the VT so easy to understand. It was a real nice presentation. I would request Dr. Anita and Dr. Kuldeep to present a memento to Shah, sir. Moving towards the next topic of conduction defects, I would like to invite Dr. Satyashan Toshniwal sir, who is a senior interventional cardiologist at Shriram Heart and Eye Care Center, Solapur.
Good evening, everybody. Thank you, organizing secretary, giving me a chance on this topic, conduction defect. This conduction defects means all my speakers will be talking about tachycardia, short, wide complex tachycardia, only tachycardia, but some of the abnormal pathways, some of the congenital defects producing some pre-excitation syndromes. I will be discussing those syndromes and everything in short. Again, the first lecture which we have, Dr. Karpe has given, heart conduction system consists of sinus node, AV node, a bundle of his, right bundle, left bundle, anterior fascicle, posterior fascicle. Then these structures are ending into the Purkinje fibers. This system is vital for initiation and coordination of the heartbeat. You see this SA node, AV node, bundle of his, right bundle branch, left bundle branch, and left anterior and posterior fascicle and Purkinje fibers. I will not be going in detail about the SA node because already Karpe sir has covered this. This is again the same thing. P wave denotes the depolarization of atria. Then QRS, depolarization of ventricle. PR interval, delay in the AV node to allow the filling of the ventricles. T waves shows ventricular repolarization. And most important, ST segment, which is a beginning of the ventricle repolarization, should be the flat one. Again, the same thing, SA node, AV node, cardiac conduction defects. Now, your heart rhythm is the way your heart beats. Conduction is how electrical impulses travel through your heart, which causes it to beat. Defects in the cardiac electrical impulse formation or conduction can lead to an irregular beat, that is arrhythmias. It can cause sudden death without any apparent cause or after stress. Any heart disorder, including congenital abnormalities of structure, that is accessory AV connections, or functions, that is hereditary ion channelopathies, can disturb the rhythm. Conditions and disorders affect electrical conduction in the heart. Most commonly, these are the arrhythmias, irregular heart rhythm, including atrial fibrillation, bundle branch blocks, heart blocks, long QT syndrome, Long QT syndrome, I would like to just highlight a little bit. Your ventricle contract and release too slowly, sometimes leading to the fainting, that is syncope, or sudden cardiac arrest. Premature VPCs, too early heartbeat in your ventricle causing heart palpitation or skip heartbeat. And last one is a sudden cardiac arrest, a severe malfunction in your heart rhythm that causes your heart to stop, resulting in death if not treated immediately. Now, some of the causes of this bradycardia, I will be not going details, but sinus node, जैसे AV node and combination of 1 and 2. Sinus node dysfunctions, extrinsic causes, these are some drugs, then electrolyte imbalance, endocrine causes, hypothyroidism, hyperthyroidism, and intrinsic causes, musculoskeletal, you see myotonic dystrophies, Friedreich ataxia, collagen vascular diseases, post-operative and congenitally. Sinus node dysfunction or ESA conduction disturbances commonly seen in the idiopathic degenerative diseases. Second commonest cause is ischemic. Third commonest cause is amyloidosis, hemochromatosis, tumors. And most common what we see is a myocarditis or pericarditis. Now, many antiarrhythmic drugs causes sinus node dysfunctions along with some antihypertensives and beta blockers. And also calcium channel blocker, cardiac glycosides, and cimetidine, lithium, and phenytoin. Slow atrial rhythm, sinus bradycardia less than 50 per minute, and causes, you know that, increased vagal tone, intracranial pressure, hypothyroidism, hypothermia, hyperkalemia, ischemic, drugs, chain stroke respiration. Now, congenital conduction defects. In this, you see Brugada syndrome, catecholamine polymorphic ventricular tachycardia, long QT syndrome, short QT syndrome, WPW syndrome, and familial lateral fibrillation. Brugada syndrome is a genetic heart disorder with an ion channel dysfunction associated with the progressive age-related conduction abnormalities. It is more prevalent in males. Diagnosis is based on the clinical and family history and ECG findings. Symptoms are often absent in the first year of life, and in adults usually manifest as a syncope or sudden death at rest or during sleep or with fever. This is a Brugada syndrome ECG. You can see this is like a RBBB pattern, and there is a Brugada sign over here. Second is a catecholaminergic polymorphic ventricular tachycardia. It is an inherited disorder characterized by electrical instability in a structurally normal heart during acute activation of the adrenergic nervous system, as in physical activity or emotional stress. Release of the catecholamines causes calcium ion channel dysfunction and myocytes, leading to ventricular arrhythmias. Spontaneous recovery from the arrhythmia is possible, but unless recognized or treated, ventricular tachycardia may cause cardiac arrest and sudden death. Clinical diagnosis may be difficult because echocardiogram and electrocardiograms are normal in resting state. Testing must be therefore performed under the stress, and preventive drugs like beta blockers, flecainide, and other treatments like ICDs and sympathetic denervation is also available for susceptible individuals. Now, coming to long QT syndrome. Long QT syndrome is a genetic heart disease characterized by prolongation of QT interval in the absence of other conditions known to lengthen it. This may lead to arrhythmia that can cause palpitation, syncope, and sudden death. Typically, long QT syndrome manifests in patients under the 40 years of age, sometimes in early infancy. Clinical diagnosis is based on clinical findings, ECG, medical history and family history. Genetic test is useful for the diagnosis confirmation. So this is a congenital long QT syndrome. You can see the QTC is 550 milliseconds due to congenital long QT syndrome. There are several congenital disorders of ion channels that produces long QT syndrome and are associated with an increased risk of torsade and sudden cardiac death. Another ECG is again the same thing. You can see the prolonged QT in hypothermia patients. Here is the QTC is 620 milliseconds due to severe hypothermia. Hypokalemia will cause again the QTC prolongation. Here the potassium was 1.9, and you can see there are prominent U waves also in the precordial. Again, hypocalcemia causes prolonged QTC, typically prolongs ST segment and leaves the T wave unchanged. Myocardial ischemia. Now, another short QT syndrome. Short QT syndrome is a rare genetic heart disease characterized by abnormally short QT interval and increased risk of arrhythmia and sudden death. Clinical presentation is heterogeneous. Some patients may totally be asymptomatic and others may have episode of syncope and even sudden cardiac death. Now coming to most important in our clinical practice, WPW syndrome. WPW syndrome refers to the presence of congenital accessory pathway and episode of tachyarrhythmias. The term often used to interchangeably with pre-excitation syndrome. First, it was described by Wolf, John Parkinson and Paul White. Incidence you can see in 0.1 to 3%, 3 per 1,000 people. It was associated with small risk of sudden cardiac death. Risk is very small. Now you can make out here ECG. ECG features are PR interval more than 120 milliseconds. PR interval is short, less than 120 milliseconds. You can see this is a normal, and you can make out this is a PR interval, very short, and presence of delta wave. You can see the delta wave, slurring, slow rise in initial portion of the QRS segment. And QRS prolongation, you can see this is a narrow QRS complex in normal ECG. Here it is a QRS is wide. Then discordant ST segment and T wave changes. You can see this is QRS complex is upstroke positive and discordant. This is a T wave is on opposite side of the QRS complex. And pseudo-infarction pattern in up to 70% of the patient you can see due to negativity deflection delta waves. Pathophysiology of the pre-excitations and accessory pathways. Pre-excitation refers to early activation of ventricles due to impulse bypassing the AV node via accessory pathways. Also these are called as bypass tracks. They are abnormal conduction pathways formed during the cardiac development and can exist a variety of anatomical locations, and in some patients there may be multiple pathways. This may be antegrade, this may be retrograde, there may be on both the directions. The direction of the conduction affects the appearance of the ECG in the sinus rhythm and during the tachyarrhythmias. So, concealed pathways in patient with retrograde only accessory conduction, all antegrade conduction occurs via AV node. No pre-excitation occurs and therefore no features of WPW are seen on the ECG in sinus rhythm. This is called as termed as a concealed pathway. This patient can still experience tachyarrhythmias as the pathway can still form the part of a re-entry circuit. You can see the tachyarrhythmias in the form of atrial. There are only two main forms of the tachyarrhythmia that occurs in the WPW. One is atrial fibrillation or flutter due to direct conduction from atria to ventricles via an accessory pathway bypassing the AV node. An AV reentrant tachycardia due to formation of re-entry circuit involving the accessory pathways. You can see the example now. Type A pattern, you can make, this is a broad QRS complex, slurred upstroke to the QRS complex. This is a delta waves. And dominant R wave in V1. This is a V1 dominant R wave. This is a type A pattern. And inverted T waves. Dominant R wave, inverted T wave, delta wave, and short PR interval. This is a type A pattern. And this is mimicking right ventricular hypertrophy. You can make out this like a right ventricular hypertrophy. Dominant R wave, V1. So negative delta wave in AVLs, negative delta wave in AVLs simulating the Q waves in the lateral infarction. This is referred as a pseudo-infarction pattern. Now this is another example. Again, you can see short PR interval, delta wave, V1, tall R wave. This T wave is on the opposite side. Again, in the AVL, there is a Q wave. Another example of this is a type B pattern. You can make out there is a almost a short PR interval. Again, broad QRS complex, dominant S wave. S wave in the V1 and V2. In tall R wave and inverted T wave in the inferior leads, mimicking the left ventricular hypertrophy. Again, this is due to WPW, does not indicate underlying LVH. So this is a right-sided type B WPW. Negative delta waves in the lead 3 and AVF simulates Q waves of prior inferior volume here. This is a pediatric fellow, 5-year-old man, 5-year-old child, where there you can see the R wave, PR short, again the delta waves. This is a 7-year-old child. And now coming to LGL syndrome, what is the difference between LGL? There is no broad QRS complex, but PR interval is a short. Again the PR interval, short PR interval with no broad QRS complex. Now another is a conduction abnormality is a sinus SA blocks. It is a disorder in the normal rhythm of the heart known as heart block, which is initiated in the SA node. Electrical impulse is delayed or blocked on the way to the atria, thus delaying the heartbeat, atrial beat. This manifests with the loss of P wave and consequently loss of QRS complex. AV block and bundle branch block, my next another colleague is going to speak. This is again LGL syndrome. Sorry. First degree SA block, you can make out delay between the impulse generation and transmission. Second degree AV block, Wanke-Bax, progressive lengthening of the interval between impulse generation and transmission, accumulating the failure of the transmission. Second degree, type 2, drop P waves with a constant interval between the impulse generation and atrial depolarization. And third degree SA block, none of the sinus impulses are conducted to the right atrium. So it's a complete absence of P waves. You can make out here. Type 1 SA block and type 2 SA block. Now AV block and bundle branch block, my another next speaker will be talking about that. Thank you so much.
Thank you, sir, for an elaborate explanation of conduction blocks. I would request, sir, please stay on stage. Requesting Anita madam and Kuldeep sir to please felicitate Satyasham sir. One small request to the esteemed speakers, please follow the time limit. The buzzer is at 15 minutes.
We have a lot of exciting lectures lined up after this as well, so request all the speakers to limit at 15 minutes, please.
Moving from the conduction defects to the further session, requesting chairpersons for the next session, Dr. Suhas Karkamkar sir, senior physician from Unique Hospital, and Dr. Pramod Pawar, cardiologist from Gangamai Hospital, Solapur. Please. Our next speaker is Dr. Rejwan, interventional cardiologist from Apex Super Speciality Hospital and Research Center. He will be discussing on bundle branch blocks.
Respected seniors and my dear friends, good evening to you all. The topic for discussion is bundle branch block. All we have seen is express heart in the form of tachycardias, supraventricular and ventricular. Now is the time to put a break. We are going to look for blocks, be it bundle branch block or AV nodal block, which are the next talks. What are bundle branches? We all have seen the anatomy and physiology of the junctional tissue of the heart. For our surprise, we all know that this is the first tissue to develop in an embryo. Before our birth, heartbeats takes birth. That means the heart starts beating in the womb of mother. This is the first specialized tissue to form in human embryo. Once we have taken birth, this keeps on beating. In this, the SA node and AV node has already been extensively covered. We are going to see AV node bundle office and subsequently the bundle branches. We are going to discuss about these bundle branches. Mainly these bundle branches extensively cover the ventricles. We all know that left ventricle is a high pressure ventricle and thus it has got more fibers on the left bundle branch. The right ventricle is a passive conduit, thus it has a very thin type of right bundle branch. These bundle branches also need blood supply. The right bundle branch is supplied by left coronary artery. So in anterior wall MI, you are going to see right bundle branch block, if at all, if it is a large infarct. Whereas left bundle branch, they are supplied both by left coronary artery and right coronary artery. Thus, either in inferior or in anterior wall MI, you will commonly see left bundle branch block. Note, left bundle branch block itself is a sign of acute myocardial infarction if it is new in onset. If pre-existing ECG was not showing any bundle branch block and now the patient shows LBBB and chest pain, it is a sufficient criteria for diagnosing acute myocardial infarction and it is the second only indication for thrombolysis. For thrombolysis, apart from ST elevation, new onset bundle branch block is the thing. What is bundle branch block? The bundle branch block may be partial or complete. Interruption of impulse conduction in the bundle branch. What is the speed of conduction of impulse in these bundles? They are to the tune of 2 to 4 meters per second. The fastest conducting tissue in the heart is the bundle branches. Fascicular blocks, we all have seen the bundle branch, the left side bundle branch divides into anterior fascicle and posterior fascicle. These are called fascicles. So fascicular block is interruption in those sub-branches of left bundle branch. These disorders can occur independently or coexist together. Usually they do not cause symptom, they are detected on ECG either in acute presentation or incidental finding. Let us see how to approach these patients. What happens if one develops the bundle branch block? Normally QRS duration is 50 to 110 millisecond. Once you get bundle branch block, there are 3 changes going to happen in your QRS. Number 1, the duration is going to increase. Usually it is more than 120 millisecond. Number 2, the waveform is going to change. The QRS waveform is going to change. Number 3, the cardiac QRS axis is going to change. Normal axis, now just my previous colleagues have told, 0 to minus 30 or 90, sorry, plus 90 to minus 30. In these cases, usually there is a deviation either to right axis or to the left axis. Same things have been shown here in ECG. What happens in normal conduction, what happens in left bundle branch block, and what happens in right bundle branch block. There are types of bundle branch blocks. It may be complete or it may be incomplete. This is purely an ECG criteria. What does it suggest? Incomplete suggests less severe than complete. For clinical purposes, both are almost same. You can see the examples of these ECG. This is an ECG with QRS more than 120 millisecond, and it is almost more than, and it is a complete bundle branch block. In incomplete bundle branch block, it is prolonged, but it is not to the tune of complete bundle branch block. So what are the causes for bundle branch block? Mainly there are 2 pathophysiologies for bundle branch block. One, the reduction in blood supply causing ischemia and the dysfunction. 2, chronic disease causing fibrosis. All these things causes either ischemia or fibrosis. Normally the right bundle branch block, we will see in detail, it can be seen in normal individuals, it can be idiopathic, it can be asymptomatic, or it may be associated with severe disorders like anterior wall MI, right ventricular strain, pulmonary embolism, respiratory like cor pulmonale, or myocarditis. Whereas left bundle branch block is more serious. Why serious? Because it supplies major part of the left ventricle, and thus if it is present, it can tell you pre-existing ischemic heart disease or hypertension or left ventricular hypertrophy or aortic wall disease or post-aortic wall replacement, or it may be just pacing of the RV or myocarditis or cardiomyopathy. The list is endless. Where do you see what is the significance of left bundle branch block? It is normally seen in less than 1% of general population. Once you see LVB, these ECGs are having broad QRS and person will identify the problem. This is an abnormal ECG. They are seen in 33% of patients with heart failure. Guideline directed medical therapy for heart failure fails when you have LVB because they are poor responders. These patients need additional therapy apart from guideline directed medical therapy. 70% of LVB patients would have either prior had LVH on ECG, and 10% of patient LVB have no clinical heart disease. Then what to do with these patients? These patients, based on the age, the prognosis is decided. If people are less than 50 years of age, the prognosis is generally good. If they are asymptomatic, no co-association symptoms, co-associated disorders. If these patients are 50 and above, then they are going to have grave prognosis. Most of the time, coexisting disorders will manifest in coming future of time. LVB has a higher risk of morbidity and mortality from myocardial infarction, heart failure, arrhythmia, high-grade AV failure, and also sudden death. LVB in ACS indicates more extensive disease. It is suggested that if you have an anterior wall MI and RBBB, ventricle is damaged to the tune of 20 to 40%. If you have left bundle branch block, it is more than 40% damage of the left ventricle. These patients tend to develop extensive LV dysfunction, pump failure, and they land up in heart failure. What is the natural history of left bundle branch block? Prognosis of LVB in asymptomatic individual remains controversial. This was studied in US among pilots for almost 28 years, and they have come up with these ideas. Data from Framingham study showed significant elevated risk of cardiovascular death, 50% within 10 years of onset. But mind it, these patients were more than 50 years of age, not younger population. More recent studies have highlighted left bundle branch block as independent predictor of adverse effect, especially age more than 50 years. The risk of sudden cardiac death is more by 10-fold. The risk of mortality from heart failure is increased by 3 times. and myocardial infarction risk is also almost 2.9 times increased in these patients. In Swedish perspective study of middle-aged men spanning 28 years, LBBB at baseline was associated with marked increased risk of high-grade AV block compared to men without bundle branch block. It also forestalls the CHB. Prognosis of LBB in younger may be relatively benign, but its presence in older subjects may serve as important marker of cardiovascular disease and death. Left bundle branch block, how to diagnose this? What happens? How is the impulse going? Block in the left bundle branch block or any of these vesicles or both, the electrical direction is deviated. Normally from AV node to bundle of his and from bundle of his to left bundle and right bundle simultaneously. From there into each vesicle and Purkinje fibers. What happens in left bundle branch block? The impulse is blocked at left bundle branch, and thus the force is directed towards the right bundle first, and the activation of left ventricle occurs later. Thus the QRS is prolonged in these type of patients. So this is a typical ECG what we get in LBBB. M pattern of complexes, QRS complexes in lead 1, AVL, V5, V6. These are all lateral leads. Lateral lead shows M pattern. Absent Q waves. My friend told already, Q waves in presence of bundle branch block suggest myocardial infarction. Left bundle branch block does not have Q waves. ST depression with T inversion. Always these ST depression, T inversions, these are all discordant to the bundle branch block patterns. QRS duration more than 120 millisecond. Usually they are associated with left axis deviation, and ventricular activating time or intrinsicoid deflection is more than 60 millisecond. What is intrinsicoid deflection? The time taken for the ventricle to get activated normally is 30 to 50 millisecond, but in left bundle branch block definitely it is going to prolong beyond 60 millisecond. Most cases have organic heart disease, recent onset LVB, think of acute myocardial infarction, presence of Q waves in lateral lead. It is never isolated left bundle branch block. You may be dealing with something different. This is a typical ECG of left bundle branch block. Already we have seen. What are the consequences of having LBBB? Commonly seen in coronary artery disease. It's an indication for STK. Already I told thrombolysis. It can be seen in valvular heart disease, especially aortic valve disease. Hypertension, cardiomegaly, heart failure, impact on prognosis, and there is something called use of biventricular pacing, which was very much geared up in early 2000 years. Now we have gone beyond this. Mainly the LBBB results in two things. There is a dyssynchrony. What is the dyssynchrony? It is also called as dyssynchronypathy syndrome. Means there is a discoordination between the ventricle. Normally there is electrical synchrony, mechanical synchrony and electromechanical synchrony. In LBBB, this pattern is lost. What is the pattern lost? The atrioventricular synchrony is lost, interventricular synchrony is lost, intraventricular synchrony is lost, because of which these patients tend to have refractory type of heart failure. They tend to need something to correct that. These electrical and mechanical dyssynchrony can be measured and gauged by various tests like echo, by ECG and by various other modalities, and they form a baseline for use of the CRT therapy. What is this? A normal ventricle will have proper synchrony going on. It will coordinate like a single unit. Whereas a dilated ventricle, you can see in LBBB, the lateral wall gets more blood perfusion, contracts more, whereas the septal area is hypoperfused, contracts less, there is a dyssynchrony occurring in them. Thus, these ventricles tend to compensate by dilatation. More and more dilatation will lead to more and more heart failure. To correct this dyssynchrony, a therapy has been invocated early 2000, that is called biventricular pacing. Who are the candidates for biventricular pacing? Presence of heart failure like class 3 or class 4 and LV systolic function less than EF less than 35, QRS duration more than 130 are the ideal candidates for CRT therapy. What is CRT? We put triple chamber pacemaker. 3 pacemakers, one in the right atrium, one in the right ventricle, the other one is to give impulse to the left ventricle through cardiac vein. And that's how we try to reduce the dyssynchrony component. Various studies have shown that patients with LBBB who received early CRT in less than 9 months of onset of thing, they tend to reverse and they tend to have a good long-term survival than those who are deprived of CRT therapy. There is new concept which is coming up. This is on an olden concept, but nowadays the hardware and software has increased. So potentially this has become a sideline nowadays for CRT. What is this? We are doing his bundle pacing in left bundle branch block. How does it act? One may think left bundle branch block is somewhere in the left bundle. His pacing is above. How does it going to overcome this block? Now what we have seen, whenever you pace the his bundle, this can overcome the bundle branch blocks. Thus, it has got a great role in management of symptomatic LBB. What we are going to do? We are going to take a special catheter and fix at his bundle. Now question comes, what is his bundle? His bundle is just 2 centimeter in length. You have to pinpoint that area and you have to put your electrode, put a screw in lead, and then this pacing gives you fantastic results. So this is a typical his bundle pacing, what has been shown here. There are some variations of his bundle pacing. Selective his bundle pacing, non-selective his bundle pacing, and left bundle branch block pacing. What does it give rise to? It gives rise to narrow QRS. The QRS are such narrow that patient will tend to have normal coordination among heart. His bundle pacing has come in a big way. Now is the treatment of choice for symptomatic left bundle branch block who has significant QRS duration in spite of CRT therapies. There are some special situations for left bundle branch block. It can be rate related or painful LBB syndrome. Just like VPC is causing pain, LBB can cause pain and it can be symptomatic. LBB in association with coronary artery disease, acute myocardial infarction, already is discussed. Aortic valve replacement or aortic valve disease, be it a surgeon doing AVR, be it an intervention cardiologist who is putting a percutaneous aortic valve, the chances of LBB and complete heart block is very, very high. LBB following septal myomectomy in cases of HOCM is very high. LBB in dilate cardiomyopathy, already we discussed, and certain forms of ventricular arrhythmia. In the topic of interest, I have just picked up one subheading, that is LBB in the setting of acute myocardial infarction. Why? Because the ECG is difficult to diagnose acute MI in the setting of LBB. Garbosa had given his criteria way back in 1996. Still today they hold good. What are they? In presence of LBB, if you have concordant ST elevation more than 1 millimeter, then that is one criteria which gets 5 score. And if it has concordant ST depression more than 1 millimeter, it got 3 score. Excessively discordant ST elevation more than 5 millimeter, it has got a less specificity and sensitivity of score of 2. Garbosa's criteria is till to date followed. It has been although modified in the year 1999 by Smith, and this becomes very potential now for diagnosing acute myocardial infarction. I think I have exceeded the time. Rest of the talk is just for theoretic. Coming to summary, bundle branch block are characterized by prolonged QRS duration, change in the waveform, and presence of change of axis. Hemi blocks typically do not cause QRS prolongation, they reveal only axis deviation. Ventricular conduction blocks are common and represent a normal variant to a serious pathology like condition. LBB itself has no specific treatment unless you identify co-associated factors with them. Coming to RBBB, generally it is asymptomatic and does not require further evaluation and treatment, and symptomatic care is more than sufficient. Doing CRT in RBBB with heart failure has been investigated and only 30% response to that. Thank you very much.
Thank you so much, Dr. Huck, sir, for bundling up the summary of bundle branch blocks in such a detail. I would like Dr. Karmakar and Dr. Pawar to felicitate Dr. Huck and with a token of appreciation. I'm extremely sorry, Dr. Karkamkar and Dr. Pawar to felicitate Dr. Huck. A round of applause by the audience, please. Speaker would be Dr. Chinmay Parle, who is a senior resident in Department of Cardiology, Jipmar Hospital, Pondicherry, who will be speaking in place of Dr. Gurnath Parle, who is a esteemed cardiologist of Solapur. His topic would be interesting signs and syndromes in ECG.
So, good evening everyone. I am Dr. Chinmay Parade. I am a senior resident in cardiology in Jipmar Hospital, Pondicherry. So, we have learned so many great things today, and I am sure this talk is just some sort of a revision for this. So, what will I be covering in this talk? So, this is a mixed bag of ECGs that I have come across in the last couple of years. Some of these are eponymous cardiac syndromes, whereas some others are some interesting ECGs which are of potential diagnostic value. So to start off with this ECG, this is an important ECG. It is the ECG of a 65-year-old male who is a diabetic and hypertensive, who has come with acute rest angina and with hypotension. So let us see what all things we see here. So it is a sinus rhythm. The rate is around 80 or 90 beats per minute. So what is important here is we see a lot of SGT changes. So we look at lead 3, we see some ST elevation happening here. But there is no ST elevation in lead 2 or in lead AVF. So there is ST elevation which is localized to lead 3. In addition, there is some ST elevation in lead V1, and there is ST depression in the lateral leads V5 and V6 with upright T waves. So this constellation of findings has been recently described and is known as Aslanger pattern. So why is this important? Because this pattern has been found to be a STEMI equivalent. So this is basically, it points towards acute inferior wall MI in patients who have multivessel coronary artery disease. So why does this happen? Why is the ST elevation localized to lead 3? So this is what is illustrated in this diagram. So normally in inferior wall myocardial infarction is what happens is we get ST elevations in the inferior leads. But here, because there is coexistent multivessel CAD, there is also a vector of subendocardial ischemia which does not localize to one particular lead as such, but it is always directed towards AVR. So the interaction of this vector here and this vector here, the inferior wall vector here, leads to somewhat cancellation of ST elevations in leads 2 and AVF, and lead 3 is the closest to the resultant vector, and that is what shows ST elevations along with some degree of ST elevation in AVR. So why is this important? Because most of the patients who present with this pattern are diagnosed with NSTEMI and are not subjected to early invasive management in the Indian setting. And this is all the more risky because these patients have multivessel CAD, so they already have poor hemodynamic characteristics and a higher mortality. So that is why this is very important to recognize this pattern. This is known as Aslanger pattern. So moving on to the next ECG. So this is a 32-year-old female who has presented with recurrent episodes of palpitations and one episode of syncope. So we have had talks on ventricular tachyarrhythmias and also on SVTs. So that has been covered, how to distinguish SVTs from VTs. So I am not going into the details. But broadly speaking, what do we see here? We see a wide complex tachycardia with a rate of around 150 beats per minute. The morphology in V1 is of a LBVB type, and there is clear-cut left axis. So some broad things to be remembered are, when the morphology is of the LBVB type and if the axis is inferior, if we are thinking in terms of VT, it is probably a VT which is arising from the right ventricular outflow tract, idiopathic RVOT VT. And when it is LBVB and a left axis or a left superior axis kind of morphology, then if you are thinking of an SVT, we should keep in mind the possibility of an atriofascicular pathway or Mahem pathway as it is known as. And the second possibility which is important to keep in mind is ARVC, arrhythmogenic right ventricular cardiomyopathy. So this patient had syncope, she was hemodynamically unstable, and so she underwent cardioversion, and this was the ECG post cardioversion. So here we see this finding here, which is known as an epsilon wave. At the terminal part of the QRS, it shows a high frequency wave which is known as the epsilon wave, and there is coexisting T invergence in V1 to V3. So this is more or less diagnostic of arrhythmogenic right ventricular cardiomyopathy. So what is ARVC? ARVC results from fibrofatty replacement of the RV free wall. And there are various criteria which is used for diagnosis, but ECG, one of the major criteria is the ECG diagnosis. And what does ECG show? Most commonly it shows T wave invergence. So epsilon waves are not the most common finding, but when they are present, they are highly suggestive of the diagnosis. So epsilon waves, T wave invergence in V1 to V3 in the absence of a complete right bundle branch block. And if the patient has VT, then the morphology of the VT is typically left bundle branch block and left axis deviation. Echo will show a dilated dysfunctional right ventricle, and the treatment for this is an ICD implant, and drug therapy includes sotalol and amiodarone. So moving on to the third ECG. So again, so this is a 63-year-old diabetic female who has come with acute onset breathlessness. So again, we see a lot of SGT changes happening here. So what is evident is there is ST elevation in lead 1 and lead AVL. So this is a points towards a lateral wall myocardial infarction. But our tendency when we look at an ECG which shows lateral wall infarction is to localize it based on the ECG to the circumflex territory. But what is also important to note here is that there is also some degree of ST elevation in lead V2. Not in V1 and V3 but only in V2. So this pattern where you get ST elevations in lead V1, AVL and V2 with ST depressions in the inferior leads, in the reciprocal leads, this is known as the South African flag sign. So this is a marker of high lateral STEMI due to acute occlusion of the first diagonal branch. So the person who is doing cath for this patient, who is doing an angiogram for the patient, should keep this in mind, should recognize this sign, because this sign might be missed, because diagonal is a branch of the LAD. In an emergency situation, it might not be looked at properly. This is the next ECG. So this is a 49-year-old male who has come with palpitations and giddiness. So again, we have a wide complex tachycardia which is irregular. Now some broad things to keep in mind. Wide complex tachycardia which is irregular, only a couple of differentials. One is there can be atrial fibrillation with a pre-existing bundle branch block, or there can be atrial fibrillation which has developed bundle branch block due to an aberrancy. And the third is of course pre-excited atrial fibrillation or WBW syndrome with atrial fibrillation. So how do you distinguish between this? So basically you look at the QRS morphology. Now we see that the QRS morphology is varying here. So in the initial few beats it is of a different morphology. In these beats here and these beats here it is changing. So if the morphology of the QRS complexes are changing, it points towards pre-excited AF being the more likely possibility. Now this patient, this is in the context of WBW syndrome, having AF is a dangerous situation because these patients, this ECG can degenerate into ventricular fibrillation at any time and the patient can have a cardiac arrest. So this has to be treated promptly. So this patient was cardioverted here and this is the ECG after cardioversion. So here we see a short PR interval and a delta wave, which is basically a very slurred QRS onset. We can make out the delta wave very nicely in the precordial leads. And now once you know that the diagnosis is WBW syndrome, the next part is localization. So if you have a tachycardia ECG, it is always easier to localize on the tachycardia ECG because there is a more amount of pre-excitation on the tachycardia ECG than on the sinus ECG. So coming back to the tachycardia ECG, what do we see here? So there are a lot of algorithms which have been described for localization of WPW syndrome, but broadly what do we look at? We look at three things. So first is whether the origin is from the right ventricle or the left ventricle, so which is based on what is the morphology in V1. So if V1 has a RBBV kind of pattern, so probably the origin is from the left side, and if it is LBBV kind of morphology, then it is probably from the right side. The second step, if it is negative in V1, then we see if there is any transition happening from V1 to V2, because V1 and V2 on the precordium, they lie on either sides of the septum. So if the pathway is of a septal location, then that will have opposite, polarity of the vectors will be opposite in V1 and V2. So if V1 has a negative vector and V2 has a positive morphology, then it points towards the septal pathway. So here we have a right bundle branch kind of a thing, so of morphology in V1, so it is coming from the left side. The transition is well before V1, there is no transition in the precordial leads because V1 is already positive. And the next thing that we look at is whether it is coming from an anterior location or a posterior location. So for this we look at inferior leads. So leads 2, 3 and AVF show negative negative polarity. So that means that it is coming from a more posterior location. Whereas if it is an anterior location, then it is leads 2, 3 and AVF will be positive. So based on this ECG, the localization of this pathway is either left posterior or left posterolateral. Now one more important thing that you have to look for on this ECG is the shortest pre-excited RR interval, which is known as Sperry. So basically you see the shortest RR interval, here it is around 5 small squares, which is around 200 milliseconds. So anything which is less than 250 milliseconds is a marker of high risk, because these patients, when they have AF, it is very likely that this AF might, condition might degenerate into VF, and they are at a high risk of sudden cardiac death. So this is what is, if the patient does not have a pre-excited AF, this forms a part of risk stratification. So AF is induced and the shortest pre-excited RR interval is looked at. So the Sperry here, because this patient had pre-excited AF, we can see that this is already less than 250 milliseconds. So this is a high risk pathway, and this pathway was subsequently ablated. Okay, so the next ECG is very important, especially in the emergency room scenario. So this is an 81-year-old female who is a diabetic and hypertensive and who was presented with altered sensorium. The first striking thing that we see on this ECG is the severe bradycardia that is present. The rate is somewhere around maybe 18 or 20 beats per minute. But what is even more important to look at is the T wave morphology. We see very tall tented T waves in the precordial leads. We are not able to make out P waves as such, and there is broadening of the QRS complex. So these are all pointers of hyperkalemia. So hyperkalemia is one situation which should not be missed in the emergency department. So reversible causes of bradyarrhythmia should always be looked for before going for pacing. The first tendency is always to put in a pacemaker, but that should not be the case. So what does hyperkalemia lead to? So the earliest and the most common sign that we see is peaked T waves. Other than this, there can be P wave widening and flattening and PR prolongation, like we have in this case, and various bradyarrhythmias such as sinus bradycardia, high grade AV blocks with slow ventricular escape rhythms. There can also be slow atrial fibrillation. There can be conduction blocks, and there can be QRS widening with a bizarre QRS morphology. So a very important ECG. All the residents working in the emergency room should always keep this in mind. Okay, so the next ECG has already been discussed, but we'll go through this again. So this is a 36-year-old male who has come with a history of one episode of syncope. So again, this is a STEMI mimic, so it is important for every one of us to know. So we see ST elevations happening here in V1 and V2. And what is important is look at the morphology of the ST elevation. So this is a coved ST elevation, and there are coexisting T wave inversions. So in the context of this clinical findings of one episode of syncope, which history-wise was typically cardiac, this is diagnostic of Brugada syndrome. So sometimes the patients might not have any clinical symptoms, or they just might have something which is some fever or electrolyte abnormalities and this ECG, in which case this is known as a Brugada pattern. So Brugada syndrome is diagnosed in the context of clinical features. So Brugada syndrome results from sodium channel mutations. SCN5A is the most commonly implicated channels. There is fibrosis in the subepicardial regions of the RV outflow tract. The presentation is with palpitation, syncope and sudden cardiac death. And there are 3 ECG patterns which have been described, out of which type 1 we have seen. In type 2 and type 3 the ST elevation is not so obvious, and it is of a different morphology. So it shows a saddleback pattern instead of the coved ST elevation that we see. In these cases, placement of precordial leads V1 and V2 can be placed in the higher up in the precordium. So if you place them up in the second intercostal space, the type 1 pattern can be brought out, or there can be drug challenge. So drug challenge can be done to bring out the type 1 pattern. Treatment of Brugada syndrome, only proven treatment is prevention of sudden cardiac arrest. So the treatment is ICD implant. For patients who continue to have shocks despite an ICD implant, quinidine has been used. And if that also does not work, then ablation is always an option. Okay, so one more tachycardia ECG. So this is a 45-year-old male who has come with sudden onset palpitations and syncope. So one finding that is quite obvious here is if you look at V1, there is clear-cut VA dissociation that can be seen. So every third beat you have a wave here. So this is probably a P wave which has been brought out. So the presence of VA dissociation says that this is a ventricular tachycardia. So this patient was cardioverted for this ECG, and then he was referred to our center. On echocardiography, when he came to us, he had global LV hypokinesia with a LV ejection fraction of 45%. But what was very interesting was his ECG when he came to us. So this ECG here showed complete heart block. So the same patient had a tachyarrhythmia in the beginning, then he had complete heart block, and he also had LV dysfunction, which was not appearing to be ischemic in etiology. So this triad of findings, LV dysfunction, ventricular tachyarrhythmias and heart blocks, if the patient has any 2 out of these 3 conditions, then granulomatous myocarditis should always be considered. And the 2 major differentials of granulomatous myocarditis are cardiac sarcoidosis and tuberculosis. So we did a PET scan in this patient, and we can see that there is uptake in the septum, in the inferior wall and some part of the right ventricle, and there are also pretracheal nodes and axillary nodes which are enhancing. Biopsy of these lymph nodes was done, and this turned out to be tuberculosis. The patient was treated with anti-tuberculosis treatment, and an ICD was implanted. Okay, so the next ECG is of a 55-year-old male who is a smoker and who has come with acute chest pain at rest. So again, this is a STEMI equivalent. That is why it is important to know this ECG in the emergency setting. So what do we see here? We see tall symmetrical T waves in the precordial leads, V2, V2, V6. There's upsloping ST depressions in the precordial leads, which is around 1 mm. And there's absence of ST elevation in other leads except for AVR. In AVR, there is some degree of ST elevation, but otherwise, and some degree of ST elevation in V1, but otherwise no obvious ST elevation. So this is what is known as D Winter's sign. This is an anterior STEMI equivalent. And it is important to remember that this might be followed by the typical STEMI morphology. So that is why this has to be treated in the emergency situation. The criteria are what we have seen in the previous slide. So coming to the last ECG of this presentation. So this is a middle-aged male who is a chronic smoker and has come with a history of chest pain 3 years back. He has come to us and at the time of presentation is asymptomatic. So what do we see here? We see deep T inversions in the precordial leads, and in the context of his chest pain and the presence of risk factors for coronary artery disease and him not having chest pain at presentation, this is diagnostic of Wellen syndrome. So what is Wellen syndrome? Wellen syndrome is characterized by deeply inverted or biphasic T waves in V2 to V3, which may extend to V1 to V6. There are two patterns, pattern A and pattern B. Pattern A has biphasic T waves with terminal T negativity, and this may evolve to pattern B, which has deep symmetric T wave inversions. There's a recent history of angina, but patients present in a pain-free state. So why does this happen? Basically, the patient has a transient occlusion of the left anterior descending coronary artery, but this gets recanalized. That is why the ST elevation gets settled and T gets inverted. But it is important that this is a marker of critical stenosis of the left anterior descending coronary artery, and that is why it has to be treated emergently. Thank you.
Amazing presentation, Dr. Chinmay. I request Dr. Karkamkar and Dr. Pawar to felicitate Dr. Chinmay as a token of appreciation. A round of applause, audience. Daunting job to present in front of a room full of cardiologists at this age, Dr. Chinmay. So, our next. So, Dr. Karkamkar, I would like you to wait on the dais as you would be the chairpersons for the next talk as well. Dr. Pawar, you as well. Yeah. Thank you so much, sir. So I would request Dr. T.R. Muralidharan, who would be our next speaker, to join us on the dais. He would be speaking on AV blocks. He is a renowned That should be enough.
Shall I? No, thank you. Good evening. At the outset, thank you, Dr. Gurunath. Thank you, ISE. It's a pleasure to be here to meet all young minds and my mentor, my teacher, Sam sir also, after years. One good news to everybody, I know we are running short of time. My topic is also going to be a short one. So I don't think I will be using all the 15 minutes, sir, for the chair people also. Thank you for allowing me. AV blocks, very important for everyone, every physician, every medical student, cardiologist, everything. In fact, AV node, the pivotal role in electrophysiology, like what P2 does for clinical cardiology or in pediatric cardiology, knowing per second sound P2, similar thing, where is the AV node, where is the signal is going to be the pivotal point for every electrophysiologist or arrhythmologist. To understand, we know the AV node is situated in this particular area of the junction of the right ventricle and right atrium, what we name it as a Cox triangle, with a tendon of Todaro, the annulus of tricuspid, and the base is formed with the coronary sinus. And the AV node, the compact part is seen often at the apex of the triangle. And the role of the AV node is maintaining the physiology and cardiac output by an optimal delay. I'm not going to go into the details of it, but the delay between the P wave followed by the QRS maintains the atrial kick and the cardiac cycle. So it's apparently insignificant role in normal sinus rhythm, but interesting and complex when the AV blocks and atrial arrhythmias. To understand a little more in detail, for a casual medical student, it is an ECG is like a PR interval. Starts from the beginning of the P wave to the beginning of the QRS complex. Normally it's 120 to 200 milliseconds. But someone interested in electrophysiology or thing, the same interval, PR interval, is divided into 3 components. That is from the beginning of the P wave, surface ECG P wave, to the atrial signal you see with a catheter located in the his bundle location, where we saw the apex of the Cox triangle. Second is the impulse has to meander through the AV node to reach the his bundle. what we call the critical delay, which is the main function of the AV node, the AH interval. And then comes the HV interval, which is with the bundle, intracardiac recording of bundle to the beginning of the QRS. So the PR interval of 120 to 200 milliseconds is divided by PA interval, AH interval, and HV interval. This is a fundamental thing, and any delay in this is going to be a reason for a AV block, depending on the severity with which you are going to see in the next few minutes. The reason, one important reason is a distal block always dangerous, and proximal blocks are most of the time benign. Of course, exceptions are there. To see, for example, in this case, what you are seeing is lead to PR prolongation. The other ECG panel also showing PR prolongation. But you go through the intracardiac thing, you see a increase in the AH interval in the first example and increase in HV interval in the second example. So same first degree heart block, what you see, where is the problem, where is the pathology going to decide about your treatment plan, prognosis and outcome of the patient. So the sites of AV block can be proximal, that is in the atrial or atrial nodal junction, and the other things are ECN block where it can be inside the bundle or infra-ECN. So sites of AV blocks are important and the types of AV block, very simple rule. Number one, first degree AV block, what it means is all the impulses are going down from the atria to ventricle, but with a delay. That's all. So first degree AV block, all impulses go down with a delay. Second degree AV block, most of the impulses goes down. Occasionally, in a regular fashion or irregular fashion, one impulse fails to go down. And third degree, nothing goes down. So if everything goes with a delay, first degree, if nothing goes down to the ventricle, it's third degree. In between is the second degree, and there are certain exceptions like this, which we'll see quickly in the next maybe 5 to 6 minutes, I think. So first degree AV block, second degree where we are going to see type 1, type 2, and a peculiar thing like 2:1 AV block, and third degree AV block. In an exception like advanced AV block and paroxysmal AV block, if time permits, we'll quickly see. We saw this ECG, normal conduction, PR interval, normal is 120 to 200 milliseconds. This is a normal rhythm without block. But if the PR interval gets prolonged, more than 200 milliseconds, we call it as a first degree heart block. As I said, every impulse goes down. Usually, many times it's benign, drug-induced, several causes, but can be a marker of a serious disease also, which if time permits, we can discuss. Like a classical example, we are seeing an ECG where you see the PR prolongation. If you measure it, it touches nearly 480 milliseconds. Classical first degree AV block. Looking to the second thing, it's interesting. Type 1 second degree AV block are the famous Wenckebach block. Though Wenckebach block can occur anywhere in the conduction system, AV block is well known, but can occur in several other sites. Okay, what it is characterized is gradual prolongation of PR interval till a beat gets dropped. So here you can see the PR interval prolongs further, fourth beat and the fifth beat doesn't go down. A typical type 1 secondary AV block or a Wenckebach block can be many times it can be in the proximal, in the nodal region, can be infranodal also, ECN also. That's going to decide about the prognosis. What you are seeing is one typical example where you see the PR interval is gradually lengthening till it drops down, till this beat doesn't go. So 1, 2, 3, 4, 5, 6 is to 5. Out of 6 P waves, 5 QRS complex, classical Wenckebach, progressive prolongation. Few things are important in this. The rule of Wenckebach, as he said several years ago, number 1 is progressive prolongation of PR interval. Number 2, progressively decreasing increments. This may be interesting for some of the interested students in the sense what we are seeing here is a typical Wenckebach cycle. But if you measure the PR interval, the 160 first beat, second is 280. So there's a jump of really 120 milliseconds. Third is 360. Though the PR interval prolonged, the first beat to second beat, the progression is 120 milliseconds. Whereas second beat to third beat is only 80 milliseconds and the fourth beat didn't go down. This is what we call progressively decreasing increments. If it happens, indirectly the RR interval going to shorten. That is what we are going to see. There will be progressive shortening of RR interval. The rule number 2, Wenckebach said, the chamber distal to the block accelerates. In fact, the acceleration the explanation is different. It doesn't really go up, but the acceleration happens, and the pause after the block is less than sum of 2 pp interval, like we see here. This type of progressive shortening RI interval and the pass will be less than sum of 2 pp interval. This is a typical Wenckebach we see. This classical finding like group beating is the easy way to identify in the practice. But the typical Wenckebach block occurs only in 50% of the cases. Many times it is atypical, and when it is narrow, almost always nodal. When the wide QRS associated, there can be nodal or infranodal, but one thing is exercise-induced Wenckebach is always due to Purkinje disease and very long PR interval. A very long PR interval favors nodal block. Coming to the second type, we saw in the first type where progressive prolongation and one beat failed to go, whereas in type 2, the PR interval remains constant except one beat fails to get conducted. So, more beats type 2, the PR interval remains constant except the one beat that fails to get conducted. Usually it is a distal disease, denotes a poor prognosis, needs for a very careful approach to a patient. Most of the time they may need a pacemaker depending on the circumstances. So, this is classical where you think a PR interval remains constant for every fourth beat fails to get conducted. This is type 2. The points of importance is you have to carefully watch for a long rhythm strip. Sometimes the typical Wenckebach, very long cycle may mimic like a type 2 AV block rather than Wenckebach. So, a careful observation of long rhythm strips are very important, and what you look for is absence of sinus flowing before the pass, and look at the PP and RI interval whether they remain constant. And combination of type 1 and type 2 direct AV blocks are very rare, and usually when they are present, most of the time it is Wenckebach itself. Or if it is defined, a refined, definite type 2 AV block second degree is usually nodal, infranodal, ECN or infra-ECN. Most of the time they may end up in a pacemaker. One peculiar situation we saw like progressive prolongation or a fixed PR, type 1 and type 2, sometimes you will have something like this, 2:1 AV block, where the one beat goes down, other beat doesn't go. So you don't know how to classify them. If I have 3 beats, if I have 4 beats, I can tell, okay, I can see PR prolongation. When one beat goes down, second beat doesn't go down, we call 2:1 AV block. This can be either first degree, type 1 or type 2 AV block. So 2:1 is a special attention. We have certain clues to differentiate. Suppose if you see a narrow QRS complex, likely to be nodal, can there be exception? Or if it's a wide QRS, we think of infranodal. Second thing is, to begin with, the PR interval is very short. Out of the 2 beats, the first beat that goes down has a very narrow PR interval, like less than 160 milliseconds. Most of the time they are infranodal, whereas if it's a very long PR interval, think of nodal. And the presence of Wenckebach before and after, keep watching the rhythm strip for several minutes. If you see some Wenckebach pattern that favors type 1 or Wenckebach block, if it is constant, that favors the infranodal one. Other thing is you challenge with atropine. We know most of the time the blocks resolve with atropine if it is nodal. It may worsen with atropine if it is infranodal, like what happened in our patient. The same patient, if you see after atropine, the atrial rate has gone up. The PP interval has shortened, but the block has progressed to complete heart block. So these are some simple clues where we can use these things to differentiate what type of 2:1 AV block. Coming to the last thing, third degree, very simple, nothing goes down. The P and QRS are totally divorced, there is no marriage. If you keep on, it marches through that. Complete heart block, several causes, benign to pathological. The treatment is being planned as per the underlying mechanism, and you see a typical case where you see the progressive complete heart block with the P wave marching through the QRS, and the QRS is narrow. That is because of the junctional escape rhythm. So the subsidiary pacemaker from the junction takes over, no impulse comes down from the atria to ventricle. Rarely it can be a distal one from the bundles or fascicles. You can have a very slow ventricular rhythm with maybe RB pattern or a left bundle branch block pattern. That is because a distal or ventricular escape rhythm. Moving to something more, we are seeing here, what we are seeing here is, out of every 3 beats, 1 beat seems to be going down, other 2 beats are not going. So it is not 2:1, it is not type 2, it is not complete heart block, we use the term advanced AV block. This type of high-grade advanced AV block, many times due to distal disease, needs careful evaluation. And before I close the last one, paroxysmal AV block is an interesting phenomenon wherein one ectopic beat, like a VPC, can precipitate a prolonged AV block. The P waves can just be there without any ensuing QRS complex, can lead to syncope, rarely can be lethal. There are newer forms are also reported, like paroxysmal AV block of this type, paroxysmal AV block due to vagal tone, or paroxysmal idiopathy AV block. Several types have come. but it's an interesting phenomenon wherein just an ectopic beat, and it is usually due to block in the phase 4 part of the depolarization. So to summarize, we have first degree AV block, second degree AV block, and type 1 and type 2, high grade AV block, and third degree AV block. And to see other way, you have incomplete AV blocks wherein all the impulses go like with delay, nothing goes in third degree, intermittently dropped beat where you have a morbid type 1, morbid type 2, or high grade AV block. Let me stop here. If there are any questions, we can take it. Thank you.
Thank you so much, Dr. Muralidharan sir. I would request Dr. Karkamkar sir and Dr. Pramod Pawar sir to felicitate Dr. Muralidharan as a token of appreciation. Thank you so much. A round of applause from the audience, please. I would request Dr. Muralidharan to stay on the stage as he would be the chairperson for the next session. Yes. Thank you so much, sir. Next, this one, the next coming session, sir. So for our next session, which is the most awaited session of the evening, I request the other two chairpersons to come on the dais. Dr. Narsimhan, who is a renowned cardiologist from AIG Hospital, to come on the stage and join Dr. Muralidharan. And also Dr. Zawar, who is also a senior cardiologist at Solapur, physician at Solapur, to join them on the dais. And now I welcome our esteemed faculty of today's evening, Dr. Samuel J. Asirvatham, who's esteemed cardiologist at Mayo Clinic, Rochester, Minnesota, USA. He has earned his MBBS and completed postgraduate work at Christian Medical College, Vellore, India. And then he went to US to pursue his cardiac and electrophysiology training at University of Oklahoma, Oklahoma City. And then pursued fellowship in electrophysiology at Mayo Clinic. He would be today elaborating on how to look at ECG. That would be his topic.
Thank you very much. So very quick preview. So this is basic. Those of you getting into the field looking at ECGs, you're already learned a lot of pattern recognition. I want to give a few points on just how you look with your mind, what message the ECG is having for us, and hopefully that will set the table for some of the quizzes, some of the talks, and the arrhythmia symposium that we'll have tomorrow. So this is called the golden rule of electrocardiography. So this rule is the fundamental for every textbook, article, or talk ever given on ECG interpretation. What it's saying is, during the ECG, we are seeing the heart's primary electrical force, the wavefront of activation. And how we recognize it is with this rule. If we know where a positive electrode is located, left arm, feet, if that wavefront is moving towards the electrode, it generates an upright wave. So R wave on the ECG, during a PVC, during pacing, during bundle branch block, you look at that and say, what it means is, I look and see which lead do I see the R wave. I should remember where the positive electrodes are located. Easy to remember, AVL 1 left side, 2-3 AVF right inferior, V1 AVR right side. And then we think, once we recognize where that positive electrode is, if that wave front is moving towards, then R wave in that lead. Corollary, if wave front is moving away, then S wave in that lead. So any R wave or S wave on the ECG, think where the positive electrode is for that lead, and then imagine the vector going to or away from that lead. This is a pervasive rule and concept. It will come in rhythm diagnosis, and some very complex ECGs can become simple if we go back and think about this. Chest leads, remember, they are not bipolar leads, they are all positive. Notice also all the chest leads are draping along the apex. Except for V1, they are all low and to the left, lowest being V6, usually defining about where the apex will be located. Now sometimes we don't see a clear R wave or S wave, we see something in between. Maybe we won't even see much of a deflection. Same rule we have to interpret. Suppose we have electrode placed here. If the wavefront moves towards the electrode, it's positive. But then it passes that electrode and moves away from it, it becomes negative. You heard from one of the previous talks about intrinsicoid deflection. That's a marker for where this changes in direction. If you see coming positive and then changing to negative, think in your mind that's when the wavefront reached that lead. So if this time is taking a long time in one lead, very late onset for that R wave and the change in the vector, that means the wavefront has started, the focus is far away from where that electrode is located. We should keep in mind that we don't have electrodes in many locations behind the heart, for example. We don't have true superior electrodes, so we have some crowding of information at the level lower and mid-level in the heart. So we have good information there. As we move away from that, behind or above, we have less information and we have to deduce more, especially for arrhythmia origin in those locations. Remember, none of the electrodes are purely doing one job. Any of them have got more than one angle in which they are looking at the heart. For example, you already heard this in the talk about ST segment MI role of lead 3 as a sole lead being showing the ST change. Notice 3, 2, AVF are all inferior leads. But the vector is different. AVF is like right under our feet. 3 is to the right. 2 is to the left. So 2 is a left-sided lead. 3 is a right-sided lead, even though all 3 of these are inferior leads. So sometimes this can be of value. You will see something you will notice is inferior origin, inferior PVC, inferior MI, inferior Wolff-Parkinson-White pathway. But it could be right inferior or left inferior. So there we just switch off the inferior leads. Where are we seeing the manifestation the most? The S wave, the negative, that's pointing to where this particular pathology is being located. You'll see many examples of this in the cases tomorrow. One word about the conduction system. Many times conduction system is represented by some cartoon like this. There is a major flaw in cartoons like this. The conduction system does not reach up to the apex before it exits to the ventricle. The ventricular entrance from the conduction system, left bundle, right bundle, the entrance to the ventricle is never at the apex, it's never at the base. It's always somewhere in between, about half to 2/3 the distance. That means anything that you see that's starting at the base, activation at the base, or activation at the apex, is not conducting through the conduction system. It's direct myocardial origin for that beat. Now, just to give flavor of how this impacts clinical practice, this simple type of vector rules. Why they become important is each region of the heart carries its own clinical meaning. For example, medical students will probably recognize this is a VT. VT in a patient, we all know, can be life-threatening. It can be very significant. You have to find the cause quickly. You have to reverse the course. But there are some other ventricular tachycardias that are benign. Patients can be reassured. You can do some medical management. You have a lot of time to think and see what is needed. One of the most powerful ways to understand whether a ventricular tachycardia can be treated as benign is appreciating the origin of the tachycardia. Origin means where is that first abnormality starting from. And a quick look at an ECG like this, just using that first principles, will tell you, is this something I can wait or something that is a disaster about to happen? So we can look at this in multiple ways. Let's just start through one or two leads. This ventricular tachycardia, if we had to venture, is it originating in right ventricular myocardium or left? Right or left, right or left? We want to think about looking at an electrode that is either a right-sided lead or a left-sided lead. So let's look at one for the ventricle always on the right side, and that is V1. V1 negative, V1 negative. Golden rule, if the wavefront is moving towards the electrode, positive deflection. If the wavefront is starting near that electrode, negative deflection. Negative in V1. That means the origin is starting close to where you place V1. And we place V1 on the right side. So already you're thinking right-sided origin for the VT, not left where most of our diseases are happening. So already we are thinking this could be a little different. Second powerful clue is you look at the inferior leads, 2, 3, AVF. All three of the leads are strongly positive. Not just positive, but large positive. What's the golden rule? Where the electrodes are, if wavefront is moving towards those electrodes, positive. Strongly positive means starting far away from those electrodes. Where are 2, 3 and AVF? The feet. What is furthest away from the feet? Our head. The part of the heart that is closest to the head is the outflow tract. And of all the places that VT can arise, a unique VT is seen from the outflow tract. There doesn't have to be cardiac disease. It's almost always benign. Maybe younger people exercise, women may be periodic. It's syndromic. It can be managed conservatively. And when drugs aren't tolerated or controlling or as a choice, very good candidates for ablation. So a whole story of the clinical syndrome, the prognosis, and your treatment options come from localization of origin. And origin localization comes from that very simple rule. Know where the electrodes are, know what R wave means, know what S wave means. So this example, just 2, 3 AVF, origin somewhere here, going towards the rest of the thing. Contrast that to this. This is also a VT, it's actually slower, but this is far worse news for the patient. It's not an outflow tract, it's wide, bizarre. V1 is positive, moving towards V1. V1 is right-sided. How can we go to the right? We have to start from the left. Left ventricle, slowish, regular tachycardia, not fitting the pattern. This is diseased heart, probably prior infarction, ischemic heart disease, or other structural heart disease. Example of why pathology can give rise to tachycardia in any pattern, but the normal heart without pathology, it's only certain areas that know how to make ventricular tachycardia. Tomorrow we'll discuss some details of the QRS that tell us about scar and cardiomyopathy in the Symposium of Heart Failure. Quick review to apply this principle of the golden rule, and I will just ask somebody from the audience to say. Everybody probably will recognize there is a pacemaker. If somebody could just tell me 3 things from this ECG applying the golden rule. Where is this pacemaker lead located? Is it likely to be effective therapy for this patient? And if you can tell me whether more than one electrode is present in this patient. Anybody? We had some very nice residents and fellows at the previous session. If anybody there, you can tell me. Or Chinmay, who just gave the talk, is he here? Yes. He gave a very nice talk.
So the QRS complex is predominantly positive in V1, but it is some sort of a biphasic.
Very good, very good. So positive in V1 means pacing electrode has to be where?
Somewhere on the left side.
Somewhere on the left side.
Yes.
Now, why would you put a pacing lead on the left side for heart failure, for resynchronization therapy? If so, you like to put the lead on the lateral wall. Is this lead on the lateral wall?
No, sir. This is not on the lateral wall. Because
You think
V6
so?
is
Think
negative.
carefully. Think carefully. So lateral, left lateral wall, the electrode closest to the left lateral wall is
V6.
left arm. Left arm. So lead 1. So lead 1 think of as pure left-sided lead.
Yes, sir.
Lead 1 is completely negative. This is the golden lead for resynchronization. Negative in lead 1 means left lateral wall is being excited.
Yes, sir.
You brought up very good point. For something so far away, this should have been bolt upright in V1, but it's biphasic. It suggests there is also a right-sided lead. Okay. Is this good placement of the lead? Should the patient be helped? Yes. We are having 2 leads and we are having something that's exciting that free wall. All of this from that golden rule. Okay. On the other hand, you look at this this ECG, also heart failure patient, also with a pacemaker, also negative in lead 1, also biphasic in V1, yet the patient has no benefit. The reason is nothing to do with the electrode position, it's these beats, PVCs. More PVCs we have, more chance of cardiomyopathy. More PVCs we have, less biventricular pacing. And we see that these PVCs are very dysynchronous, very wide-looking PVCs. So same thing, we are looking at the PVC and we are looking at origin to try and see if we can ablate. Maybe very quickly, if you can tell me, successful ablation for this PVC in the right ventricle or left ventricle. Just think from that golden rule.
So these PVCs are upright and inferior leads. So they are
Yes, upright and inferior leads, so coming little higher.
higher up.
Which ventricle?
Left ventricle, sir.
Very
Because
good.
V1
Excellent.
is
Excellent. That is a complete analysis of the ECG based on a first principle rule. No memory needed, no prior knowledge needed, just deduction and understanding. That's our way of looking at the ECG. Thanks a lot for your attention. Do you want to do a question? Should we do a question?
Thank you, Sam. I think I can't hear a better person talking about the vectorial analysis of how to deduct information from a simple 12-lead ECG. It was a wonderful talk. And are there any questions? Well, there are no further questions. Any other? I think we'll close this session.
It was a wonderful session by Dr. Samuel. So we would be moving on to our next session now. So thank you so much, chairpersons. I would request the audience to be patient for just a moment. So we would be moving on to the next session. I would request the next chairpersons, Dr. Shubhangi Dadke and Dr. Siddhant Gandhi, to come on the dais, who would be chairing our next session. The speaker for the next session would be Dr. Santosh Kauthale, and he would be speaking on the topic of STEMI. I would request the chairpersons again to come on the stage, Dr. Shubhangi Dadke and Dr. Siddhant Gandhi.
Thank you very much, particularly organizing committee, for inviting me. Good evening all. My job is already done by previous speaker, just I have to rebrush the things. Everybody knows what is ST elevation myocardial infarction. There should be complete and persistent occlusion of a major coronary artery. Then we will have ST elevation myocardial infarction. So why this is rapid diagnosis of an accurate diagnosis of STEMI is vital for early reperfusion therapy, that is either thrombolysis or primary angioplasty. which will definitely improve the prognosis in STEMI. So time is muscle, and early diagnosis is very important. And ECG is a simple, easily available, cheap, rapid investigation. What is important is interpretation of ECG, that is most important. I will not go again, everybody knows the normal ECG, but this segment is very important. This segment is very important. QRS segment is due to ventricular depolarization. And second important segment in STEMI is ST segment, which is isoelectric period following QRS complexes. This segment roughly corresponds to plateau phase of ventricular action potential. So ST segment is very important in the diagnosis of ventricular ischemia, because under these conditions, ST segment can become either depressed or elevated. And that means either patient will have non-ST elevation myocardial infarction or ST elevation myocardial infarction, while T wave represent ventricular repolarization and positive deflection. AHA criteria for diagnosis of STEMI: first prerequisite is ischemic pain. Rest angina, patient should have ischemic pain or rest angina, a discomfort or any kind of angina, rest angina, any discomfort from lower incisor to up to umbilicus. Any pain or discomfort from the lower incisor to up to umbilicus, patient may have angina. Then second is ECG changes, third is cardiac enzymes, and you can take the help of echo if it is available. So broadly, you don't go into detail, but broadly in limb leads, their ST elevation should be more than 1 millimeter, and in chest lead, ST elevation should be more than 2 millimeter in two contiguous leads. So 1 millimeter and 2 millimeter in two leads. So this is a criteria for diagnosis of STEMI. Problem arises when patient has pre-existing bundle branch block. At that time, you cannot apply this criteria when patient is having bundle branch block, and oftenly missed myocardial infarction, ST elevation myocardial infarction in presence of LVB. So you have to apply this Garbosa's criteria. So what is this Garbosa's criteria? ST elevation more than 1 mm in leads with positive QRS complex. Positive QRS complex means lead V5 and V6 when there is ST elevation more than 1 mm. Then second criteria is ST depression more than 1 mm in lead V1 and V3. And third criteria is ST elevation more than 5 in lead with negative QRS complex. So first criteria points given 5, second criteria point given 3, and third criteria points are given 2. So if score sum of 3, these criteria have a specificity of 90% for detecting myocardial infarction. Few more signs in presence of LVB. It is very difficult to diagnose the STEMI. So few more signs can help. Those are not very specific, but it can help. This is called as Cabrera sign. What is Cabrera sign? There is notching in V3 and V4. This notching in V3 and V4, upsloping of S wave, V3 and V4 notching, it has very poor sensitivity. Although it helps in diagnosis of STEMI, in suspicion of STEMI, but it has very poor sensitivity. Then one more sign that is called a Chapman sign. Again, there is notching in 1 and AVL. It has low sensitivity, but specificity is very high. So Chapman sign and Cabrera sign can help in diagnosis of myocardial infarction in presence of LVB. Then how ECG in ST elevation MI, ECG is always evolving. There will not be any fixed waveform. Waveforms will go on changing. So within minutes, we will get the hyperacute T wave. In clinical practice, we rarely see this hyperacute tall tented T wave because it occurs very early phase, within minutes to hours. Usually patient won't reach to our hospital. So very rarely we get such type of hyperacute T waves. Then this phase is very important. If patient come in this phase and if you revascularize the patient will be completely covered. His heart muscle will be saved. Lot of heart muscle will be saved. Almost normal heart you can give to the patient in this stage. Second stage, after minutes to hour, within minutes to hour, necrosis starts setting. Once necrosis starts setting, there will be ST elevation with terminal negative T waves and negative T waves. This can last for days to months. And finally, after few days or after few weeks and months, you get pathological QO. So this is isolated ST segment, then ST elevation, then biophysic T wave, completely inverted T wave, and again this T wave become upright and finally appears pathological QO. So these are evolution in ECG during myocardial infarction. This picture is very important. Both this is a diagrammatic diagram of coronary, rough diagram of coronary angiography, and this is leads, ECG leads. As you know, the left main, on left system there are two arteries. The left main bifurcate into circumflex and LAD gives lot of branches like diagonal septal, then circumflex gives obtuse marginal, then on right side is right coronary artery which give important branches of PLV and PDA. And if you put together this diagram and this diagram, then we'll come to know which part of heart is infarcted or which part of heart is going to die or going to necrose. So this figure is very important. Right-sided lead, right, V1 and V2 represent interventricular septum and right ventricle. Anterior lead, V3 and V4 represent anterior wall of left ventricle. Low lateral lead, V5 and V6, low lateral wall. High lateral leads like 1 and AVL, high lateral wall. Inferior lead 2, 3 AVF, inferior basal surface of ventricle. Then right ventricular abnormality. There are no lead looking directly to the right ventricle. So right-sided lead like particularly V4R, and there is no directly we are putting the lead on posterior side of the heart. We will have indirect evidence of suspicion of the posterior wall infarction on limb lead V1 to V3, which is a mirror image of posterior lead. So sometimes you have to take V7, V9 leads. If you know all these things, and this AVR is cavity lead, always negative in normal patient. So this diagram and this diagram you put in your mind, then it is very easy to diagnose which kind of myocardial infarction, in which vessel, where myocardial infarction is there. So again, just to revise this, anterior MI V1 to V6, septal MI V1 to V4, then lateral MI 1 AVL V5 V6, inferior MI 2 3 AVF, posterior MI V7 V9 V8 V9, right ventricular MI, right sided leads. Few example if time permits. This is one example of hyperacute T waves. See this T waves in V1 to V3. This is hyperacute anterior wall myocardial infarction. Patient very early within minutes. This is another example. This is very tall R wave and very high ST segment elevation. It is called tombstone R waves, very high. Then inferior wall MI with reciprocal changes in lead AVL V1 and V2. There are ST elevation in inferior leads, and 1 and AVL there is ST depression. Inferior wall with right ventricular involvement. Why this is important? Isolated inferior wall and plus right ventricle and posterior ventricle involvement. Particularly in right ventricle involvement and posterior involvement, if you give the diuretics and nitroglycerin in such patient may have hypotension. In fact, they will respond to fluid challenge. So diagnosis of right ventricle infarct is very important. Whenever you have inferior wall myocardial infarction ECG, always do right-sided lead, that is V4R. That should be dictum. And if there is ST elevation in right-sided lead, that is V4R, V4, 5 or 6 right-sided lead, the diagnosis of right ventricular involvement, and where we have to very cautiously give the diuretics or nitroglycerin very cautiously. You know how to put right-sided lead. I will not go into detail. Then inferior wall with posterior MI. If you see, there is ST elevation in inferior lead, but ST depression in V1 to V2. V1 to V2. Then if you do the posterior lead, V7, V8 and V9, there is ST elevation. So each and every inferior wall MI, right-sided lead and posterior leads are very important. Usually it is forgotten, but remember that in every inferior wall MI, you have to do right-sided lead and posterior lead. Then how to put the lead, I will not. If you see such patient comes to you, there is gross ST depression in V1 to V3. Whether you will thrombolize this patient or not. Because ideally, if you look at this ECG, this looks like a non-stimulation type of ECG. So you will not thrombolize this patient because indication for thrombolysis is ST elevation. So whenever you get ST depression and very severe acute chest pain suggestive of rest angina, then you have to do these lead, V8 and V9, posterior lead. Although isolated posterior wall MI is very rare phenomena, but still, whenever you get the ST depression in anterior leads, don't think that this is an ST MI. It could be ST elevation MI. And if you don't have cath lab, particularly at the periphery, where intervention facility is not available, this is very important. You have to rely on the ECG changes, and accurate diagnosis is very important. And this patient will be benefited by giving thrombolysis. Then how to differentiate between RCA and circumflex inferior MI? In both you will get the ST elevation in 2-3 AVF. RCA MI ST elevation is more than lead 3. ST elevation is more in lead 3 as compared to lead 2, while circumflex ST elevation either equal or less. So this is another example of massive inferiolateral wall MI, particularly if you get ST elevation in V5 and V6, prognosis is very grave, and usually patient will have multi-vessel disease rather than single vessel disease. This is example of RCA. This is 3. See, this 3 is more than 2. ST elevation that in 3 is more than 2 usually suggests this is RCA is complete vessel, and associated reciprocal depression, T-wave inversion in 1 and AVL and ST elevation in AVR. Circumflex MI, if you see 2 and 3, almost equal, and there will not be any reciprocal changes in 1. There may be reciprocal changes in AVL, but there will not be any reciprocal changes in 1. So whenever such type of picture, there is ST elevation is similar in 2 and 3, and no reciprocal changes in 1, and only reciprocal changes in AVL, and it could be in circumflex artery. Anterior wall MI, there are confusing terms are used in defining anterior wall MI. Some says it is anteroseptal, anterior, anteroseptal, anterolateral, extensive anterior, anterolateral. The more as proximal vessel, more extensive MI. This is hyperacute anteroseptal MI. ST elevation is basically, rather than ST elevation, there is very tall T waves in anterior leads. This is extensive anterolateral MI. Why extensive? All leads, 1, AVL, V1 to V6, all leads there is ST elevation and reciprocal changes in inferior lead. This is example of extensive anterolateral myocardial infarction. Again, this is another example of this what you call a Tom stoning pattern. There is huge ST elevation in almost all lead and large ST depression, significant ST depression in inferior leads. This carries bad prognosis. Early reperfusion is very important in such patients. Then position, I will go in short. This particularly the LAD positioning. Where is MI? MI before arising any branch, either septal or diagonal, that is called osteoproximal LAD, and that could be, this is very important kind of MI where prognosis is very much guarded. See picture. This is ST elevation in all leads, and there is QRBB, that is RBB plus there is RBB. So prognosis of such patient is guarded, and immediate revascularization is required in such type of patient. LMCA, always taught that LMCA occlusion. There is LMCA, whenever there is LMCA occlusion, there will be ST elevation in lead AVR and V1. So you should not ignore the AVR. But 100% occlusion of LMCA in clinical practice is rarely seen because patient will have sudden cardiac death due to simultaneous anterior, lateral and posterior wall ST elevation MI. Sub-occlusive LMCA, not 100% occlusion of 95% stenosis, you get the ST elevation in AVR and VVR and ST depression in all leads. Such type of picture you can get in severe triple vessel disease also. D Winters T waves, already previous speaker Dr. Parade has highlighted on this. This is also very important. Why this is important is regarding thrombolysis in periphery. Although there is no classical picture in D Winter waves, These candidates are for fibrinolysis or fibrinolytic agent in periphery. Then last slide. First, what changes? First, large peak T wave, hyperacute T waves, then ST elation, then ST negative T waves, and finally pathological Q waves. And precaution, what precaution you have to see that ST segment elation associated with an evolving myocardial infarction is often readily identifiable, but knowledge of common pseudo pattern, infarct patterns is essential to avoid unnecessary use of thrombolytic treatment or urgent CAG. Thank you very much.
Thank you so much, sir. A brilliant presentation on the topic that matters for all of us. So I would request Dr. Dhadke and Dr. Gandhi to felicitate Dr. Kauthale with a token of appreciation. And I request all the audience to give a very huge round of applause for sir. I can see that many PG residents have taken down notes on this, since it is a topic that has mattered for all of us. So now I would request our next speaker, Dr. Ketan Mehta, who is a consultant cardiopulmonologist from Mumbai. He would be speaking on the topic of ECG in stress testing.
Good evening, friends, respected chairpersons. At the onset, I must admire still the audience, the postgraduate students are still there at the fag end of the day, and I know, though I am probably the last man, because before a very interesting session which is coming up right now after this is the ECG quiz by none other than Dr. Narasimhan sir. Friends, now you heard about the ECG, and I'm going to talk about ECG in stress testing. I'm sure you all are knowing those stress testing, the utility which started going down, but still it has a definite role in clinical practice, and we cannot forget that. We know that in spite of there are so many false positives and false negative which are there with the ECG changes, we know the meta-analysis have shown that overall sensitivity of 68% and specificity of 77%, which has been there with stress testing. So it has a definite role and need to be rightly positioned over there. Now, I'm not going to go into the details of stress testing, which I'm sure all of you know. A certain salient points pertinent to the ECG, which I'm going to talk about, which is, when we interpret the ECG, it is the why, what is the clinical reason for which if a particular test has been stopped, hemodynamic data, where, you are monitoring the vitals, and is there any evidence of ischemia or arrhythmias. So again, in that you need to see the time to symptoms, ST segment changes, and number of leads involved over there. Now, friends, you must know there are certain normal ECG changes in stress test, and which are a normal with a physiology also. So that you must remember the QRS complex, which decreases in size, PR, QRS, and QT shortens as the stage advances. J point, slight depression which can happen, it can result in up to upsloping of ST segment. ST segment returns to baseline by 80 milliseconds, and that's how you know that when we start interpreting, we take it at 80 milliseconds post J point. PR segment may downslope, which is also a finding. R amplitude can decrease, P amplitude will increase, and T wave decreases. So these are the findings which are physiologically happening in a stress test. Now, let's look at this electrocardiographic response. When you see the normal ECG, which is a pre-exercise, that's how you always look at the pre-exercise ECG. So ideally, you always have a look at it, and then you start looking at what are the changes which can come up. So there could be a J point or junctional depression which can happen. You look at the upsloping ST depression, you have a various points. So your ST depression can be upsloping, can be isoelectric, it can be downsloping also. So this is upsloping ST depression. So J point is down, but then there is a ST segment which is going up. So this is a upsloping ST depression. So though ST is depressed, the slope is upward. Then you can have a horizontal ST depression. So J point is down, but it is horizontal, and then you have a downsloping depression, which is the most important when we have to look for it. Then sometimes you will come across ST elevation, and of course the U wave inversion which can come up. So these are all the features which you would look into it. Now, as I said, as you proceed in an exercise ECG, the points you would look at whether the isoelectric point, you look at the J point, and then you look at the 80 millisecond post J point. So these are the 3 points which you will be focusing on. Now, as I mentioned about ST segment depression, so ST segment depression, you have the junctional depression with rapidly upsloping ST. So here you can see the ST which is rapidly up. Then you have another one which is a horizontal ST depression. Then again in that you can have a significant one, or even you have a 0.2 which is much more significant. So higher the ST depressions, again it has a more significance. Downsloping ST depression, again which carries the highest value, as I was mentioning also. So again you need to look into these features also. Now, when you look at the various findings, if you have to divide it, as I was mentioning, so you will have either there are no ST depression or J point only depression without any significant changes at 80 milliseconds, or you have a upsloping ST depression. Now, if you have these first two findings, which will be interpreted as negative ECG response in a stress test, if you have a upsloping ST depression, it would be equivocal, especially if it is not a significant one. And if you have a horizontal ST depression or downsloping ST depression, it will be considered as a positive response. Now, upsloping ST segment depressions, as I already mentioned, the J point depression may be normal, but ST at 80 milliseconds, if it is less than 1.5 millivolt, then of course you need to look at what is the slope. Slope should be more than 1 millivolt per second. So that is very important. And if there is a slow upsloping, it is indicative of a fixed obstruction. So again, that is more relevant also. Now you must keep it in mind, false positive ST depression, and there are a number of causes which can lead to false positive ST depressions, right from anemia, digitalis, cardiomyopathy, uncontrolled diabetes, electrolyte imbalance, hyperventilation, left ventricular hypertrophy, interventricular conduction defect, patient who is having underlying pre-excitation with aortic stenosis, severe volume overload state. So these are the few conditions which you should be keeping in mind. Now, ST segment elevation, the J point elevation of more than 1 millivolt in 3 consecutive weeks, again has to be taken with the quite severity. Now you need to again look into whether infarct territory with Q waves and whether it is a non-infarcted territory with non-Q waves. And if you have ST segment elevation in non-infarcted territory, it is indicator of transmural ischemia or vasospasm with critical narrowing, which is possible. Now let's look at few examples. Now this is at rest, you look at lead V4. Now in exercise in 2 minutes 50 seconds, you can see the significant ST depression which is seen, which becomes little more pronounced at 4 minutes 30 seconds, and in recovery still persistent. So this is definitely a strongly positive stress test. Now this is another example where you can see the at rest ECG, and during exercise look at what happens. V1, V2, V3, there is a ST elevation. V2, V3 is the highest ST elevation. Again, this is a stress test which is positive. Now, you must also remember that sometimes, the ECG pattern in which the ST segment becomes abnormal only at a high exercise. That means here you can see that 8 minute 50 second it starts becoming abnormal. At 12 minutes it is much more abnormal, but you need to look at whether the patient is asymptomatic or not and how much is the METs achieved. So if there is a significant METs achieved at that point of time and those ECG pattern returns to recovery early, you don't have to worry about it. You don't put it as a positive stress test. Now T-wave changes, as I mentioned, ST segment changes are more important than the T-wave changes. The T-wave changes can be influenced by body position, respiration, hyperventilation, certain drug, myocardial ischemia and necrosis. So there is, of course, though ischemia and necrosis can give rise to T-wave changes, but those are not the only one. Now, pseudo-normalization of T-waves. Now, this is again a pattern which has been described that, a person who has at rest T-wave changes, that becomes upright. These are not very specific or suggestive of ischemia, though there are papers which shows that you must consider ischemia in these patients also. Ectopics, which occurs in 70 up to 20% of patients who undergo stress test, but does not appear to be an independent predictor of adverse outcome. So ectopics coming up doesn't mean it's a positive stress test. Now this one additional component, QT dispersion, that is difference between maximal and minimal QT interval of a 12-lead ECG, and dispersion is increased with ischemia. And when you have a ST changes, that is ST depression and this QT dispersion, both are used. The criteria here, the specificity can increase up to 100%. Now, these are the certain factors that preclude the interpretation of exercise stress test. So, if you have underlying pre-existing patterns like LBBB, LVH with strain pattern, Deach-Stock effect, so that would be, I am sure, would be difficult to interpret in that. Now, let's quickly look at certain ECG cases. Now, this is a 62-year-old lady, had an atypical angina, at heart rate was subjected to stress test, and that is at peak exercise. This was the changes lead 2, lead 3, AVF, and in the lateral leads also. So this is at heart rate which was 112 at 7 meds in stage 2. These are the ECG changes. This is definitely still a positive stress test. Look at another example. 51-year-old male complains of breathlessness and on exertion. Had a previous, of course, the anterior wall infarction, had undergone PTCA in the past. He is known diabetic. And now on treadmill, he develops this pattern. Look at the ST depression in inferior and lateral leads. He had old anterior wall and now he got this pattern. He is a positive stress test. Look at another example. Again, as I mentioned also, peak exercise, there are changes, and the changes which become more pronounced in recovery, take it more seriously. So this is the subject where if you see the changes have become more pronounced ST depression, so this is again a critical case. Another example, you will come across this such type of patients also. This is the resting ECG, and on continuation has developed this. I am sure you are aware about, you need to have a defib ready in a stress test room because your patients can develop arrhythmias which can require defibrillation and this is the example where it has been found also. Now another example, here it's a 76-year-old man with long-standing hypertension, on diabetic. He is complaining of recurrent light-headedness and syncope with physical activity. So obviously you start evaluating what happens over there. His resting heart rate is around 65, ECG shows sinus rhythm except first degree AV block, nothing significant. So he was subjected to a stress test, and look at it, what happened. This is exercise induced complete AV block. and that was the reason of he getting syncopal attacks again and again. Also, you should keep it in mind the false positive ECG changes during exercise with pectus excavatum. So because of that, you will get those changes, but you must examine the subject beforehand. So in a patient with pectus excavatum, these are the findings. Another things you should look for is during exercise trials, false positive which can happen in computer synthesized rhythm. So you need to always also look at the row strips. So that is also one thing which you should keep it in mind. So ladies and gentlemen, to summarize, the exercise ECG stress test has reasonable sensitivity and specificity for the detection of ischemic heart disease. You must know the probability of underlying coronary artery disease when you are subjecting somebody for a stress test. So you will able to interpret it in a much better way. Though there are false positives and false negatives, both can happen. The clinicians who are ordering an ECG stress test should be aware about its limitations, should know what are the relative contraindications and absolute contraindications, and should do for a specific subset of patients. And if you can detect it, yes, stress-induced ischemia, you have done a major thing over there. So I would end with this ECG patterns, which are classical indicative of myocardial ischemia, which you should be keeping in mind. And there are certain patterns which are not indicative of myocardial ischemia. So just changes does not mean it is a positive stress test. So these are the basics which you will keep it in mind, and hope I have completed in time. Thank you so much for your patient hearing.
Thank you so much, sir. You were perfectly on time, right on time. So I would request our chairpersons, Dr. Dhadke and Dr. Gandhi, to felicitate Dr. Mehta with a token of appreciation. A round of applause by the audience, please. Thank you so much, sir. Moving on to our next topic, that is the most awaited event after the guest lecture, that is the ECG quiz. So I would request our chairpersons for the ECG quiz, Dr. Mukund Zambre, who is a senior physician at Zambre Clinic, Solapur, to come on the dais. And joining him would be Dr. R.R. Agrawal, who is also a senior physician from Solapur. Also, I would be inviting Dr. Basavaraj Sutar, who is a cardiologist from Yashodhara Hospital, Solapur. I request the chairpersons to join us on the dais, and conducting today's quiz would be our esteemed quiz master, C. Narasimhan, who is from the prestigious AIG hospitals. He would be conducting the ceremony.
Just something about the quiz. So we have around, I think, 11 teams participating, and out of this, we will select top 5 teams for the finals on Sunday. So they will be eligible for a 15,000 rupees cash reward and a life membership of ISE. The quiz Dr. Narasimhan will be conducting. There will be 15 questions and 20 seconds for each question. The answers will be from a team, not as an individual. So if you have the team name ready, or one person from the team, you have to name it on the answer sheet. Yes, over to Dr. Narasimhan.
They're going to write it down? How does it operate? I think, good evening all of you, and these are rapid fire questions. Some of them may be very basic, but we thought as MD physicians, we need to know some of the basic concepts. So we'll start with the first case.
So wait a moment, we'll call the students. I request all the MD students to come forward and have a seat at the front row so that they can have a better look at the screen. We want you to be fast, so you have to, and you have to sit as per your teams. Sit together as per your teams, please. 2 people in one team.
Do they have a writing pad or something to note down? How do they?
Yes, they have a writing pad.
They have been given? No, I don't see them carrying. Hope there's a seat here. You can come to this side. We'll first present the questions.
Is anyone remaining? I request the participants to write the name of their team and name of both the participants in the paper given to them. And also, one gentle request to all the audience members not to prompt answers from the back. Although we know that all of you know a lot of things, but no prompting from the back.
Are we all set?
Is everyone ready? Should we start, students?
Shall we? Okay.
Okay, yeah, we'll be starting.
So this is the first ECG. The choices are given below. This is a patient with a dual chamber pacemaker. The choices are fusion, pseudo-fusion, pseudo-fusion, loss of capture. Where is the timer? 15 seconds, sir. Okay. This is the next ECG. This is a patient who comes with the exertional chest discomfort and was found to have normal coronary arteries. And this is what we find when the patient walks, like a stress test. How would you treat this person? Do you give him a beta blocker? Consider a pacemaker, conduction system pacing to correct the bundle branch block, or none of the above?
20 seconds for each question. Your time starts now.
We'll move on to the third. This is a patient with atrial fibrillation, has been on treatment. How do you manage this patient?
Time starts now.
Choices are hemodialysis, maintain potassium above 4, permanent pacemaker, none of the above.
Time over.
We'll move on to the next question. We'll come back to discussing the correct answers at the end of it. This is a patient who presents with palpitations to casualty. How do you treat this patient? Beta blocker, calcium channel blocker, amiodarone, or propafenone?
Time starts now. Time up.
This is a patient who complains of recurrent syncope, and this was the Holter that was obtained during eating. Holter was there and the patient had a pre-syncope, and this was what was obtained. Diagnosis is sinus node dysfunction, complete heart block, paroxysmal AV block, none of the above.
Time starts now. Time over.
These things are very relevant in your day-to-day practice, these questions, because if you understand the concept, you can prevent a lot of drug-related side effects. How does potassium channel blocking drug demonstrate its effect on the surface ECG? How do you know that a particular drug is achieved its therapeutic efficacy or it's achieving its toxic level? By looking at the QRS duration. Does it shorten the QRS duration? Does it shorten the QT or lengthen the QT?
Time starts now. Time up.
So this is not an uncommon situation. Patient is admitted into your ICU, recurrent VT, repeated shocks, it's incessant, repeated cardioversion. Patient is on lidocaine, IV amiodarone, it's not able to suppress the arrhythmia. What is the next best drug? What other drug might you suggest? Appropriate therapy. Is it esmolol, procainamide, bretylium, or deltaesem?
Start. Over.
Which drug exhibits the properties of all the Vaughan Williams drug classification? 1, class 2 effect, class 3 and class 4. Which drug has all the effects combined in one? Is it procainamide, flecainide, mexiltine or amiodarone?
Start. Over.
Bidirectional VT is a symptom of which toxicity of which drug? Is it digoxin, amiodarone, quinidine or atenolol?
Start. Stop.
Patients on amiodarone should have monitoring of these tests: liver function tests, TSH, ophthal exam yearly, chest X-ray and pulmonary function tests. All of the above or none of the above?
Start. Over.
This 60-year-old gentleman with recurrent heart failure is found to have normal ejection fraction. What is the cause of the heart failure? You can see the ECG there, lead 1, 2, 3, AVR, AVL, AVF. These are precordial leads, and this is a parasternal long axis echo. Is it due to coronary artery disease that is coming back? Is it hypertrophic cardiomyopathy? Is it cardiac amyloidosis or cardiac sarcoidosis?
Start. Over.
So this is the electrocardiogram of a patient. Diagnosis. Is it 6 sinus syndrome, second degree AV block, or complete AV block?
Start. Over.
What is the diagnosis? Is it left bundle branch block, acute coronary syndrome, hyperkalemia, or hypernatremia?
Start. Over.
Now this patient is admitted into the ICU with some unknown drug toxicity, and is getting this repeatedly, this kind of tachyarrhythmia. How do you treat this person? Magnesium, pacing, IV isoproterenol, or all of the above?
Start. Over.
This was obtained, we were called for a consultation for a VT. This top strip is running, what you see. What kind of VT is it? Is it polymorphic VT? Is it pre-excited WPW? Is it atrial fibrillation? Or is it artifact?
Start.
I should thank Basavaraj for capturing it.
Over.
Okay. I think we have stopped there. And I hope you had enough time. You can collect those papers. We can have that for discussion.
Please mention the name of the team and the name of the participants both on your answer sheet so that we can identify who are answering how much.
Okay. So we'll start with the first ECG. It's a little bit of a, for a tie we could have had this ECG. Can I have the ECGs on the screen, please? So what you have is in a dual chamber pacemaker, you can see a spike, which is the atrial pacing spike. Following an AV delay, there is a ventricular pacing spike. In a person with a right bundle branch block, the lead is generally placed at the right ventricular apex. But because of the right bundle branch block, even though the ventricular activation has started, by the time the lead sees the depolarization is much later. So the lead doesn't see the ventricular depolarization for the set 200 milliseconds and then it delivers the spike. But it falls on the refractory period. You understand what I am saying? So what do you mean by, suppose there are two wavefronts. A part of the ventricle is getting depolarized by the pacemaker. A part of it is getting depolarized by the normal His-Purkinje system. That is called a fusion. Here, the pacing spike falls on the QRS, but doesn't do anything to cause ventricular depolarization. It appears like fusion. So it's called pseudo-fusion. Why is this important? Because if you recognize this, it's unnecessarily draining the battery. It's not doing anything, it's unnecessarily draining the battery. So this is pseudo-fusion. So I think some of you would have heard the term as painful left bundle branch block syndrome. Whenever a person has a left bundle branch block, the septum gets depolarized, so the septal contractility starts and it just stretches the lateral wall, and then the lateral wall depolarization starts. Remember, the coronary perfusion is in diastole. And during diastole, the left ventricular free wall is actively contracting. With the result, there is a functional ischemia completely because of delayed depolarization of the lateral wall. So this is a rate-related bundle branch block. As the heart rate increases, the left bundle branch block arises, and the treatment for this is just to slow down the rate. Whether it's you give ivabradine or beta blocker, the patient will feel better. The drug of choice is beta blocker for this condition. Now, this is an old dictum in all our medical textbooks. Whenever a person with atrial fibrillation is getting treated with digoxin, suddenly it will normalize. So, this is a sign of digitoxicity. Atrial fibrillation, we expect the RR interval to be varying. Sudden regularization of the RR interval indicates that the patient has developed a complete AV block, and there is a spontaneous depolarization from the node. It could be either a nodal rhythm or idioventricular rhythm, and this is very, very typical of a digitoxicity. And digitoxicity can be mitigated by maintaining the potassium level above 4 or giving intravenous magnesium. Of course, if the patient is sick, you may put a temporary pacemaker, not a permanent pacemaker, so that choice goes out. The diagnosis here is fast, broad, irregular, pre-excited atrial fibrillation. So, exactly, all the impulses are coming down to the ventricle through the accessory pathway. In these patients, giving any drug which slows down the AV nodal conduction, like beta blocker, calcium channel blocker, will directly cause further acceleration of the ventricular rate. So the correct choice is either giving intravenous procainamide or propafenone in this patient. They selectively act on the atrial myocardium and not on the AV node. What is this? This is a typical thing what you have as a person for deglutition syncope. When a person is swallowing, when the patient develops a syncope, it's deglutition syncope. It can be micturition syncope, it can be deglutition syncope. The clue is it's not sick sinus syndrome or a sinus node dysfunction, because you don't have a PP slowing, there is no RR, everything suggests that there is a vagal activity, the PR prolongs at the end of it. The PR is long, and this suggests that there is intense vagal activity causing asystole. So this can happen, for example, in trigeminal neuralgia, glossopharyngeal neuralgia. So it behooves on the part of the physician to evaluate the esophagus. One of the common reasons is esophageal spasm, which can cause this kind of a problem. Any severe painful stimuli, from a visceral organ can cause this kind of a problem. The treatment, it doesn't need any pacemaker. You treat the underlying cause, everything will be all right. How does a potassium channel blocking effect of the drug demonstrate on the surface ECG? Any takers? Lengthens QT. Why is this relevant? Because even potassium channel is effectively blocked by drugs like erythromycin, azithromycin, quinolones. These are all drugs which act on the potassium channel. So these are common day-to-day drugs, psychiatric drugs that you use, amitriptyline, imipramine. They can all cause this kind of a problem. So these are commonly used drugs. When such a patient comes to you with syncope or a pre-syncope, it's important you need to do at least an ECG to make sure that the QT is not prolonged. What is the correct answer for this? CCU with recurrent near incessant VT. Yes, the drug of choice in any electrical storm is not lidocaine, it's not amiodarone, it is again and again and again beta blocker. And the drug of choice in a beta blocker, there has been which is the best beta blocker in an electrical storm? Which is the best beta blocker to use in an electrical storm? Propranolol, the good old Inderal, has mortality benefits compared to metoprolol, all the other beta blockers put together. So, of course, here the only esmolol is mentioned. So, esmolol, the advantage is it's got a very short half-life. The disadvantage of the drug is a very expensive drug. So, but if you are worried that the patient is developing pulmonary edema, LV dysfunction, you can turn off the drug. That's the biggest advantage of esmolol. Which drug has properties of all four von William classification? Amiodarone. It has calcium channel blockade, beta blockade, class 3 effect and class 1C effect. So it has all the properties and amiodarone is the correct answer. Bidirectional VT is due to toxic levels of, it's a manifestation of digitoxicity. So digitoxicity can paradoxically present as an accelerated spontaneous automaticity of the several pacemakers like AV node or the spontaneous His bundle activity, but at the same time can slow down the conduction. The commonest manifestation is atrial tachycardia with block. One of the rare extreme variety is bidirectional VT. Now the reason why I put this amiodarone monitoring is we use amiodarone like water. Please remember, as a clinician, you don't realize the patient can develop right from blindness to severe thyroid storm to irreversible lung damage. So it is important that when you use amiodarone, you need to monitor these patients very closely for the side effects. Now, I am sure all of you are internal medicine graduates. Which of the pulmonary function test is the most sensitive to pick up amiodarone toxicity? DLCO, you are absolutely right. DLCO, diffusing capacity is very early, it goes down. And if you have a facility, because you can pick up ILD much before the patient develops an irreversible lung injury. And that is the importance. Diagnosis here. Whenever you see a low voltage on the ECG with LVH, generally with LVH we see very big voltages. When you see LVH, we would have expected tall QRS complexes, whereas here the QRSs are very minuscule, and this is typical of a cardiac amyloid. Can anyone tell me why? So cardiac amyloid is not true myocardium. It is all amyloid deposits between the myocytes, so they don't generate any QRS voltages. Actually, it will attenuate the QRS voltages. So this is typical of whenever you see LVH on echo, but very small QRS on ECG, that is typical of cardiac amyloid. What is the diagnosis here? 6 sinus, second degree AV block or complete AV block. Whenever you see constant RR interval and varying PR interval, the diagnosis, it means the A and the V don't talk to each other. It's complete AV block. Yes or no? So ventricle is going at its own rate, atrium is going at its own rate, and there is no relation, PR is completely varying. So it fits in for every criteria for a complete AV block. Diagnosis. This is a must-know ECG. That is the reason why it's, even though it is basic, whenever you see a widening of the QRS and an effacement, you don't see an ST segment. When the QRS merges into the T wave, when the T wave becomes hyperacute, this is typical of hyperkalemia. The reason is you don't wait for the lab results. In your lab, it may take 3 hours, 4 hours. If you wait for 4 hours, you lose the patient. You need to start acting immediately. How about this? This is typical of an R on T phenomenon, which is seen in patients with a long QT. This is bradycardia related long QT, and the treatment includes all of them. You increase the rate, at the same time give intravenous magnesium, you should be able to tide over the crisis in this patient. What is this? It's an artifact. You see a lot of VT-like morphology because the leads have come off, but you see a normal arterial pressure going on simultaneously. Arterial pressure is normal, blood pressure is normal. ECG shows, in fact, Dr. Basavaraj was called into ICU for a VT based on this ECG. Luckily, he had his photograph and captured it. And this is an artifact. I think we'll stop here and we'll have the final rounds, or if there is a tie, we'll have the second round of questions later on. This 36-year-old female with heart failure, presents with heart failure, ejection fraction is 30%. MRI is normal. The diagnosis is heart failure with sinus tachycardia, dilated cardiomyopathy. It's atrial tachycardia, or the patient has an ostium primum ASD.
Start.
This is so. This is a patient with running supraventricular tachycardia, and as you can see, there is a PVC that terminates the tachycardia, and then the sinus rhythm comes back. So let me just again explain. Supraventricular. So what do you think is the mechanism of the tachycardia? It's AV nodal reentry. Is it atrial tachycardia, or is it AVRT? That is axillary pathway mediated tachycardia.
Start. Meanwhile, the contestants are answering the questions. I request all the guests to be seated and not leave the hall, as we will be having a orchestra after this, which will be called Nath Brahma. It will be a gentle entertainment program after this. Stop.
Okay. So this is a patient who is in the surgical ICU post-gastrectomy, and day 2 has syncope. And this is the rhythm strip that you see, normal rhythm, and then patient develops a rapid tachycardia. The mechanism is what? Is it automaticity, re-entry, early after depolarization, or delayed after depolarization?
Start. Stop.
So keep on shocking the patient, patient will not improve. What is this? On Holter strip, this was obtained. Patient came for evaluation of pre-syncope. Is it VT? Is it VF? It's artifact, or is it atrial fibrillation with aberrancy? Done?
Stop.
So this is a 64-year-old person with diabetes, hypertension. Is it sinus tachycardia with LVH and sinus tachycardia, AV nodal reentry, atrial fibrillation or atrial flutter?
Start. Stop.
Okay. I think we'll stop with this. We'll see what happens.
Okay, sir.
Meanwhile, you can take it from them. We'll discuss these ECGs. So the first ECG is to understand what looks like a normal P wave. You don't have a completely negative P wave in lead V1. You'll have a biphasic P wave in a normal sinus rhythm. So whenever you see an atypical P wave, you should think of an atrial tachycardia as the cause of the heart failure. Because this patient, if you don't, there are 10% of patients with pediatric heart failure are related to tachycardiomyopathy. They almost go to transplant if you don't recognize and treat them. This is a tachycardiomyopathy because of a crystal tachycardia, high crista. It will very closely resemble sinus tachycardia. This is not the one. So this is the mechanism. For an AV nodal reentry, the reentry is happening within the AV node. One single PVC cannot go and penetrate the AV node because it will collide with the impulses coming into the His-Purkinje system. Whereas if there is an accessory pathway, it can easily go and terminate the tachycardia. So the one PVC terminating, that too late onset PVC terminating a tachycardia is diagnostic of AVRT, accessory pathway mediated tachycardia. Now the reason I put this up is because if you understand it, this is due to early after depolarization, this polymorphic VT due to long QT, any kind of bradycardia will worsen this situation. Whereas if it's delayed after depolarization, tachycardia will worsen the situation. Automaticity cannot be controlled by defibrillation, whereas re-entry will be controlled by defibrillation. So understanding the mechanism helps you to treat these patients better. So this correct answer to this is early after depolarization. What is this? You can see the QRS marching through here. There is a QRS here, there is a QRS buried here, there is a QRS buried here. So actually you can see the QRS marching through these artifacts. This is all an artifact which shouldn't be labeled as VT or VF. I think this patient actually is misdiagnosed as sinus tachycardia. What you are seeing is actually an atrial flutter. You can see two P waves, one P wave at the end of the QRS, one here, one at the end of QRS. Compare the sinus rhythm P wave, which is completely different. So patient had atrial flutter 2-to-1 conduction. This is not a sinus tachycardia. Okay? I hope it's all right. The correct option is atrial flutter. 4. I think that's the last one, no? Yeah. Thank you. Again tie.
Again, it's a tie.
Can't believe this is like the Wimbledon going on.
Can we have one more ECG? Both
Yeah, I think so. They've done so well. Include both of them, no?
So
They've
both
done
the
very well.
teams would be
Congratulations.
included.
Congratulations.
Congratulations to both the teams. Yeah. Yes. So I thank Dr. Narasimhan for this exhaustive session on ECG quiz. And I thank everyone for being so patient and waiting through all these exhaustive sessions. So after this, I would like chairpersons to felicitate C. Narasimhan sir. So after this, we would be having a entertainment event, which is called as Nad Brahma.